Well, good morning everybody and welcome to this morning's Children, Adults, Health and Wellbeing Policy Development and Scrutiny panel. And welcome to everybody. As usual, I'll just ask everybody just to go round and so we are certain of who's who. Obviously, many of us will have our names and position on a sign in front of us. For those that don't, I'm sure Mark will in future make sure you have a sign. Okay, my name's Dina Romero and I'm the chair of this panel and I represent South Down in Bath.
My name is Liz Hardman. I'm vice chair of this panel and I represent Porton Ward.
Michelle O'Doherty, represent Newbridge Ward.
Mention if you vote or not. Would you mention your voting or non-voting?
Yeah. Christopher Batten, National Education Union representative, non-voting member.
Councillor Paul Crossley, Dina's colleague in South Down.
Hello, Alex Beaumont, Kincham North.
Hello, Joanna Wright, Lambridge Ward.
Morning, Kevin Burnett, National Association of Head Teachers, part of representing the professional associations, non-voting member.
Morning everyone, Victoria Stanley. I'm the programme lead for community pharmacy, optometry and dentistry working for BSWICB.
Hi, I'm Helen Wilkinson. I'm the community pharmacy clinical lead at BSWICB.
Morning everyone, Laura Ambler. I'm the Director of Place for Baines at the BSWICB.
Morning, Cathy McMahon. I'm from the Baines Council Public Health Team, Development and Commissioning Manager.
Hi, I'm Millie Carmichael. I'm also in the Public Health Team. I'm a Health Improvement Officer.
Hello, I'm Paul Scott. I'm Associate Director in the Public Health Team here at Baines Council.
Hello, morning. Becky Reynolds, Director of Public Health and Prevention in the Council.
Good morning, Claire Thorogood, one of the Assistant Directors in the Health and Social Care Director at Baines Council.
Good morning, Anne Smith, Assistant Director of Adult Social Care Operations for the Council.
Hello, Alison Bourne, Lead Member for Adult Services.
Good morning everyone, Mark Jones for Democratic Services.
Morning, Kerry Williams, and I provide the scrutiny support for the panel.
May I just say, please, could everybody try and speak directly into their microphones? I know it's difficult when we have our various devices, the laptops particularly, often mask, mask the microphone itself, and so makes it difficult sometimes for people to hear. So, thank you for that. Okay. So I'd now like to turn to Mark to talk us through the emergency evacuation procedure.
Great, thank you, Chair. Yes. Oh, got my wrong bit of paper. That's good stuff. There we go. If the continuous alarm does sound, you must evacuate the building and proceed to the assembly point. From this room, you follow the green running person signs to the exit, using either the marble staircase or the main staircase. Please do not use the lifts. The assembly point for this building is Orange Grove grassed area just outside Baines Restaurant. And there's an evacuation chair for use by disabled people who so wish in the corridor outside the Council Chamber Public Gallery. Alternatively, the area at the top of the marble staircase has been designated a safe refuge where persons needing assistance should assemble. Thank you.
Thank you very much, Mark. And apologies for absence. I've been notified that David Harding is not able to attend due to sickness.
Okay.
Are there any others?
I'm just aware that Councillor Mansell is unable to attend today as well.
Thank you very much. I don't believe there's anybody else who is missing. Alison?
Suzanne Westhead is unwell, so is unable to attend today.
Okay, thank you, Alison. Okay, any other absentees? Okay. So the next item is declarations of interest. I've not been notified that anyone has any declarations to make, so we'll move on. Urgent business. I've not been asked to notify the panel of anything, but I would just like to say that we have there has been a further meeting of the Knife crime task group, and I wonder perhaps in future if we might want to just have a little summary of what's happened that we will append to our agendas in future. Would that be acceptable to everybody?
Yeah.
Yes? Okay, thank you. Right, the next item is public questions and statements, or indeed from councillors. I have not been notified of any. Now we move on to the minutes of the 13th of November. And the first thing I would like to do is to apologise for one action that was minuted that I did not carry out, which was to formally write to the Cabinet Member for Adult Services around our disappointment in how the news of Charlton House was conveyed to us. So I apologise to the panel for not taking that action on. We have had a small discussion about how in future we will ensure that such actions are carried out in future. I have no excuse for not doing so, so I just apologise. Okay, but we do have the Cabinet here who will be talking at length about Charlton House and the consultation in future. Okay, are there other comments people want to make on the minutes? No? I did have a couple of notes from David Harding about areas that he had perhaps emphasised differently, and I'll pass those on to Kerry to amend. One was around dental hygiene, and his point was actually about extractions. So perhaps when you're talking about dentistry, which I think is the item is in January, you'll be able to pick that up then. And then there was another comment again that he made, which was, although not recorded exactly as he had wanted, I think we can again talk about a bit more at a future meeting. And this was around COVID deaths, particularly at the RUH and other hospitals. So perhaps we can pick that up in March when I believe the item is on that agenda. Okay. Any more comments on the minutes? Kevin?
Just a quick one, but I'm assuming, Chair, that it may come up at the next meeting with the education focus, but I haven't received anything in writing from the Director of Education around allegations review being carried out of the review allegation process, safeguarding and schools. That hasn't come yet, not to my knowledge, it has come to you.
I think I've seen it either.
That's on page 15.
Page 15. Okay. So this is about domestic homicide reviews.
No, sorry.
Sorry, the managing allegations protocol. Is that
That's
what
it. Yep.
Sorry, I'm just quickly. Okay, so can we follow that up, Kerry? It's, do you see where it is? The Director of Education Safeguarding replied he would provide further information in writing to the panel. And that's a review of how allegations are processed and who is involved in that process. So it's sort of midway through that page. Okay, thank you. Any more points on the minutes? Okay, so with those various amendments, are we happy to note the minutes? Okay, thank you. Right, we now move on to the Cabinet Member update, and thank you for the circulation of that report, Alison. So do you have anything further you wanted to add to that report?
No, I assume everyone's read it, and I'm happy to take questions. Unless there's anything particularly you want me to highlight, I think it's fairly clear.
Okay, so to the panel, are there any points you wanted to focus on? No? Alison, sorry, Liz.
I've been given two names here. Who am I? Alison, you mentioned about the shortfall in occupational therapists, and there's an 8 months waiting time. And I know of residents in my ward who are saying that it has taken 8 months to be seen, to get things like rails outside their homes and things like that. And you said that you're going to refocus the workforce, the occupational therapists' workforce, which will help decrease waiting lists. Do you think that will happen, or do you just need more money, more occupational therapists for this to happen?
I mean, I think the biggest problem is that there is a national shortage of OTs, and that shortage is apparent locally as well. It's not currently our service, it's with HCRG, so we've asked them to come up with a plan for what they can do, and this is what they have got in their plan. So I think they will be looking very carefully at how they use the resources they have. But the bottom line is that they don't have sufficient resources because there aren't enough OTs available.
Well, I suppose that leads neatly to the question, what can be done about that then?
Yeah. I'll hand over to Anne because we have got some plans for when the service comes back in-house.
Thank you. So once the service comes back in-house on the 1st of April, we are planning to launch and invest in 4 occupational therapists apprenticeships. We are currently working.
Yeah, I'll give everyone a couple of seconds just to finish settling down after our unexpected trip outside because of a fire alarm. Okay. Thank you very much, Mark. You are a man of many talents. Oh, sorry, I didn't mean to touch your screen. Feel free to. So now, where were we? I think we were talking to the cabinet member. Did we get to the end? Thank you. Of course. Yes. What will we do about it? Anne, what are we going to do about it?
Thank you, Chair. So as I was saying, we are planning to invest in 4 occupational therapist apprenticeships, and we are currently working with our local colleges and providers around that. So once the services transfer, as Councillor Bourne rightly says, we have asked HCRG for a plan around reducing the waiting times for occupational therapy assessments. We are also asking our Community Wellbeing Hub and Live Well to support us in signposting individuals where it is a simple item of equipment that somebody could perhaps purchase for themselves. So we've asked our HCRG colleagues to look at the number of people who are waiting for more simple items as opposed to people who need a major adaptation or an adaptation through a housing provider.
Thank you. Sorry to just dwell on this just a little bit longer. You said that we're investing in apprenticeships. Do we actually have enough young people who are actually interested in this type of work? And if not, what more can we do?
So our initial discussions with both the University of West of England and with Bath College is that people are interested in occupational therapy. Often a barrier to that, as we know, is the cost of going to university. So apprenticeships offer us a really good opportunity to use our apprenticeship levy, which means that course fees are covered and people get a wage. So what we've seen with social work apprenticeships is you often get a lot more interest than just offering people a normal university route.
Thank you. Then I'll come to Kevin after I've had one final follow-up question, which is related to the low numbers in occupational therapy. Obviously, social workers in general, in care homes, etc., you know, we hear nationally there are not enough people who are choosing these professions. You know, often low wages are cited as one of the reasons, lack of sort of career progression, etc. Are you doing a similar piece of work to address those shortages?
Thank you, Chair. So there has been recent successful recruitment of 10 newly qualified social workers into HCRG last year. That was following a number of apprenticeship programmes which the Council was fully supportive of. We have looked at our salaries for social work, occupational therapists and specialist posts such as mental health practitioners. Our council does compare favourably within the South West. However, where we do have some differentials, such as with nurses and with approved mental health professionals, we have offered a market supplement. But we are struggling with the recruitment challenges, as you say, that all local authorities are.
Thank you very much, Anne. Kevin and then Joanna.
Thank you, Chair. Under finance, you have got down there about the actions taken to reduce expenditure for the rest of the year. Could you say a little bit more about what actions are being taken and their impact, please?
Yeah, so shall I start? We're freezing, well, we haven't completely frozen recruitment, but we are looking very carefully at every post that we're recruiting. So we're slowing down recruitment and only recruiting where it's strictly necessary. We're also looking at packages that people have and checking that we're not doing any duplication or that that we're using our money very wisely on those, and we're putting in increased controls on discretionary spend, and we're also looking at maximising the income that we get. So those are a number of measures that we're taking, and we've only been working on them for a fairly short time, so we don't yet know the impact, but in the new year we should be able to see what impact that is having, but it should be helping bring things back in line.
Yes, thank you. A couple of other questions, please. You said the CQC inspection is due very shortly or at any time. How do you currently rate your inspection grade?
I'm happy to take that answer, Chair. As we notified Scrutiny that we around the outcome of our peer review is our best indication of how we would perform under a CQC inspection. Scrutiny have quite rightly asked to see the outcome of the peer review, and we were scheduling to bring that back to Scrutiny before and in line with publication. Our peer review outcome was very positive. We have some work to do around some areas to get us ready for inspection, and we need to update our self-assessment prior to asking Scrutiny to look at our self-assessment. So far, I think we are on track to receive a good report, but you would never want to be overconfident in those areas. And those people who've lived through Ofsted would understand that reticence.
Thank you. Under your paragraph on work with the RUH, there's a withdrawal of the temporary community hospital ward. Just wondered what the pressures are that's being created as a result of that, and also how does that fit in with the new resources to support the discharge process, if that's part of the discharge process?
I can take that one if helpful, Chair. So, as we know, the difficult financial position that we find ourselves in does mean that we have to make difficult choices. And we did have a community ward, Homewood. It was always intended to be a temporary ward. And as we know, it has helped us very well with the discharge process so far. The funding is not available to continue that ward beyond the 30th of November, so that ward has been closed. I can confirm that all of those that are on that ward have been successfully discharged, and that we do have mitigations in place. As you know, this is in line with our winter plan. Scrutiny might remember that I've spoken before about we're looking to reduce reliance on bedded care and provide more around community. So actually, we have managed this, we continue to mitigate it, but inevitably it will continue to add to winter pressures, any reduction in the bed base. I don't think there's anything further to add unless any of my social care colleagues have anything else to add. No.
Do you have more questions, Kevin?
Final thing I think was around the new supported living scheme and whether these are part of the new 40.5 million boost for improving care with learning disability and autistic people.
So I'm going to cover that in my update. Can you repeat the question again? I didn't quite hear. What were you looking to see if it was included?
Yes, it was about the new supported living scheme, and are these part of the new 40.5 million boost that was being given?
I see. Yeah, no, that's separate. So the 40.5 million boost is direct funding from NHSE, and I'll give you an update on that in a moment.
Thank you.
And these schemes are funded through the council. They're council schemes, so they're completely separate.
Thank you. Joanna.
Hi, thank you. Just picking up still on the occupational therapist's role. I mean, we know that actually keeping people in their homes is one of the most important ways of saving money for all budgets across the board. So I just wonder, one, if there's a link between the occupational apprenticeships and the budget generally within the council and how we're spending things, and whether we should actually have a paper that comes forward about the use of apprenticeships is for enough. How is that paid for? Where does that budget come from? What was my other point? How long does it take to get somebody who starts as an apprenticeship ready to be a fully occupational therapist in place? And you know, the waiting list is massive, so I can see that the whole thing is linked to other decisions within the budgets elsewhere, and that failure, that's not your failure, it's the failure of the system of many years of organising things. We're going to have to, if we can spend more money on occupational therapists, we could actually save a huge amount elsewhere. So I'm just wondering where the cross links are being made and in which areas is that being done better or could be done better, and what could we maybe send to the other scrutiny panel on budgets about how we really think that this is high priority and that the council should be backing this and being seen to be taking this further.
A very good point, Joan. We also have budget papers coming to this panel, I think in January. Yeah, the savings and income proposals will be coming to this panel in January, so it'd be useful maybe to pick up that point then as well.
I think it's a good point, though, that it would be useful, I think, to maybe bring a paper about apprenticeships And I think it's absolutely right that apprenticeships are a really useful way of growing the workforce in areas where there are shortages. And that's why we have been doing that with social work and occupational therapy. But there may be other opportunities, and maybe we should be trying to do more, because I think you're absolutely right that if we don't have enough OTs in the system, then it causes blockages and people get stuck and they don't get their needs met in a timely way, and it really is problematic, and we should be doing everything we can to try to address that.
Thank you, Chair. Just to pick up on your point, Chair, about other scrutiny panels, I think Councillor Wright makes a valid point in terms of we can bring more information about the role of occupational therapy, how additional posts would support that. But I think also perhaps to bring that in the context of what happens then next for individuals, whether it's waiting for equipment or waiting for a disabled facilities grant, so you see the totality of the picture and the path and journey that people need to go on.
Joanna, do you have any additional questions?
No, I'm just making sure that in our minutes we have an action on this in some form.
Okay. So we've got it penciled in as a full plan item at this moment. Okay. Right. Any more questions on the Cabinet members' update? Okay. I've just got one question, which is around unpaid carers and co-production, and I guess it's that almost unanswerable question about what we don't know. So, you know, if we think we have X number of carers, how many more carers are there that we don't know about, and how can we better reach out to those, so A, to recognise the role that they play, and B, that they have the support that they need.
I mean, I think we have got some fairly recent data on carers actually from the census, and that shows the number of people who identified themselves as carers through the census process, and that's probably an underestimate because not everybody will. But actually I was discussing this in a meeting on Friday, and across the southwest, the numbers of people identified as carers within local authorities falls far short of the numbers identified in the census data, and the numbers of people receiving support falls far short. So there's clearly a lot of work that all local authorities, including us, need to do, and that's what we're aiming to address through our new carers strategy and the work that we're doing on that. But yeah, I think it's really important that carers do get the support that they need, but we need to be better at identifying them in order to do that.
And I assume that the strategy will include intelligence from other places, from perhaps health and perhaps other bodies that might come into contact with people who might not recognise themselves as carers. And are there other barriers perhaps to people identifying themselves as carers, in the same though that we know that for young carers perhaps there is a fear of what might happen if they do let anybody know what the situation is at home. So I just wondered if those points would be picked up.
Yes, I'm sure they will. I mean, I think GP practices have got an important role to play in identifying carers, and some are better than others, so probably if we did work with them, that would help getting consistency. Also for young people, most of them are in education, so again, schools have got an important role to play in that, but we need to ensure that all of those are feeding in to help identify carers.
And we've spoken then of two bodies, schools and GP surgeries, which we know are under huge pressure, giving them another job. Sorry, any more questions on the Cabinet members' update? Okay, in that case then I would like to move on to the Baines, Swindon and Wiltshire Integrated Care Board update. I don't know, Alison, if you wanted to speak first, or otherwise I'll move straight to Laura to ask us to take us through this.
I'm happy for you to go straight to Laura.
Thank you. So, Laura, do you want to give us any more insights in addition to the paper that you've already circulated? I do notice that we have something on screen that we might move so we can look at it more without a pillar in the way.
Thank you, Chair. Yeah, so I understand that you've had the update report, and just a reminder, I think, Chair, you asked me to flag if there's anything that we think we specifically need your support on, or if there are any comments that we're specifically looking for. This is a genuine update report, so there are no actions for the panel as such. I'll set out broadly the items and the headlines, and then, as you say, Chair, I think the key focus today is on our community pharmacy update, and we want to make sure that we leave enough time for those. And as you know, I'm here with my health colleagues, Victoria and Helen, who will take us through that. But before we get there, if I just flag some of the headlines in the report that I know you have seen and will assume as read, we do have the fantastic news of the 40.5 million that has come from NHSE. That's to improve care for individuals with a learning disability and autism in the South West, who may need support with mental health and would benefit from acute mental health support. What that funding will do is fund 2 new 10-bedded units. Now, one we are the lead commissioner for in Bain, Swindon and Wiltshire, and that will be based in Bristol. One will be in Devon. They're designed specifically to care for individuals with a learning disability and autism, in particular for those that wouldn't be able to have their needs met within a mainstream setting, even with reasonable adjustments. So crucially, these new facilities have been designed with the voice, lived experience voice and input from service users, their families and carers, and it will be a specialist therapeutic setting where, as we know, there'll be shorter stays, therefore, and support in the community. So this is a very different type of offer, and we're very excited about that. That will come on stream summer 2025. So those new facilities are in train at the moment, and we'll bring you further updates on that. The report also talks a bit about Orchard House, which is another fantastic bit of news. So this is our new community crisis house in Midsummer Norton. The panel will remember I spoke to you about this before. And what we've done now is just provide you with a little bit of an update, how it's providing step-up and step-down support with people with mental health needs broader across the population. This is provided by Bath Mind, the panel will remember, and it provides accommodation 365 days a year, 24 hours a day for 4 people at any one time. And in the report you'll see some photographs actually of Orchard House, and just to demonstrate and understand how it really is a different offer there as well, dedicated quiet therapy space, etc. So some fantastic bits of news there. On that theme, RUH have also provided us with an update around the first non-invasive prostate cancer treatment being carried out in the South West. So this is the first time that has been successfully carried out. It's focused on high-intensity focused ultrasound, and as well as the lead consultant at RUH, they've been working with a world-leading expert professor at Imperial College, the Charity Prostate, and the UK Ultrasound Foundation. So this will improve access longer term, and as I say, that's a real piece of innovation and the first of its kind in the South West. The 2 other updates in the report are around discharge planning, which we've just had a bit of a conversation on, and the focus on home is best, and also industrial action. So I'll pause there for a moment, Chair, just in case there's any comments on those, and then I'll hand over to my colleagues who will talk us through the community pharmacy presentation that the panel have requested.
So it's a bit previous, I think.
Sorry, Chair.
I followed my leader.
So I open the floor up then for any questions on Laura's update.
Only one. I'm just circuitously going back to the previous question in a way, but just to ask around, I know you closed the beds and you wanted to focus on community care for the discharge. Obviously, when you close something and it's being used, there are certain things to overcome and get right, and resources to put in different places. with this new resource as well, has that filled the void of that community ward closing, or are you more than compensated for that and were well prepared for it anyway?
Yeah, that's a really good question. So I'll try and unpack that a little bit, if I may. So the panel will remember that we've talked about winter planning before, and we have a winter plan that's in place. And as I say, Homewood was part of the original winter plan, and we have utilised Homewood as a temporary resource. It had around 16 beds, and we have now looked to close those beds, and they closed on the 30th of November, as I say, and the focus being on home is best and discharge planning. So Homewood did help, in terms of having that flow of discharge planning, but we have other mitigations in place now. So the panel may recall that we talked about virtual wards. So our virtual wards, the number of beds or equivalent beds that are available through that have more than compensated for the number of beds in Homewood. So we currently are around 80. So we are in line with trajectory. Just a reminder, some of those beds are step-down beds, so they're for people who have been in an acute setting, so in the RUH, and with clinical support they're able to now move home and be supervised. And some of them are step-up, and our HCRG partners are supporting with that, so that's preventing avoidable admissions in the first place. So a combination of those two models makes up our virtual wards. Alongside that, obviously, we have a number of other things in Baines. So we've spoken before about the Community Wellbeing Hub, and I think we're looking to put that on your forward plan to come and talk to you a bit more about what that does. That absolutely helps in terms of broader discharge planning and actually a wider range of access to other services. So there's a combination of things that I think we have done that will more than mitigate for the closure of Homewood. I suppose what I'm saying is that inevitably, as we go into winter pressures, of course, all of these things, will have an impact, and it means that we have to work really hard to keep online with our winter plan, which was always to reduce reliance on bedded care, because we think home is best, and we're trying to make sure that we keep people within their own homes and with the support that they need in the community. So we keep a watching brief on that. So I hope that explains a bit more. Yeah, thank you.
Kevin?
Yeah, just to follow up that point about you at the hub and points of contact. And again, I know we've spoken about this before, and you were still saying that the actual points of contact in the community are still something you're working around. And just to raise again that issue, which I raised before about the issue about when to contact and who to contact. And most people, well, sadly, are naive enough to still think I contact the GP if I think I need something, but I'm not sure what. We might go there first. And even now, the sort of my local GP's surgery was saying there was no bookable appointments for a while, which means that I've got something that I think I might want to talk, but I don't think it's urgent, and I don't want to ring in every morning to say to the GP, I think I need to speak to you, because I don't think it's that urgent, and then those concerns get pushed further and further back. So I hear you keep bringing up the hub, and I understand the hub, and I think many professionals may use the hub to refer people if they come into contact with them, but it's getting to that point. Do you see what I mean?
Absolutely, and I agree. So at the moment we have a single number for the Community Wellbeing Hub, so you're right, GP surgeries can refer into there, indeed the acute hospitals might, community hospitals might, and we have a hub and spoke model, so we actually have a physical presence of the Community Wellbeing Hub in the atrium of the RUH. What we're looking at is also making sure that our communities know that that resource is there, so that physical in the RUH helps, but that only helps if you're in the RUH for something else. So we do have a single number that is available for communities to call. What we're working on is a self-referral process, and we need to think about what that looks like. And indeed, we're working closely with primary care, and we're working closely with the Community Wellbeing Hub just to think about what does that local care coordination look like. In Baines, we're lucky that we have the HCRG Local Care Coordination Centre as well. So there are a number of front doors, or to put it another way, no wrong door, to be channelled into the right way. But you're right, it still is reliant on people coming into one of those access points, which is why I think we need to do a further piece of work about how people can self-refer. And and make that really visible for people. And then I think what I spoke about last time is, more broadly, we need to think about that across the whole system. So not just Baines, but Baines, Swindon and Wiltshire. And we are also considering that alongside. So I think we have an awful lot in place, and we're very fortunate in Baines, but there are some tweaks and improvements we need to make. And part of that, as we've spoken before, is how those systems talk to each other, things like integrated care records and what have you. So we can come back on that another time, but I'm minded that when we come back on the Community Wellbeing Hub, why don't I set out some of that within that report? That sounds like it'd be a useful thing to do.
Thank you, Laura, and I'm sure Kerry's made a note that we will want to see that within that report, and that we'll have it on our work plan. Thank you. Can I come back to you in a moment, Eleanor? So I want to do the panel first. Okay. Liz?
Thank you, Laura, for telling us the good news that we've got extra NHS funding, but it's across the southwest. So does this mean that patients from Baines are going to be in competition with a lot of other people? So it's only going to affect a small number of people, of our residents?
Yeah, thank you. That's a really good question. So I think just to clarify a few things, this is the first time that we've actually worked across integrated care boards, so intra-ICB, if you like. What we have looked at is a demand and capacity model. So we are looking at what is the demand across the southwest for people who have learning disabilities and or autism and would benefit from acute mental health support. So whilst there'll be more beds within the southwest, it doesn't mean that there'll be more people that will be needing to utilise that support. It's only the people that need it. So the demand work tells us that that is the right number. In particular, sadly, I think about 50 to 60% of that cohort at the moment are placed out of area because we don't have the facilities in the southwest. So obviously the intention is that that will reduce this. So we're confident this is the right number to plan for our own capacity for Baines, but also broader. And as I say, for the north of the patch, if you like, so for Gloucestershire, Baines, North Somerset, South Gloss and BSW, we are the lead commissioner, and in the south of the patch it's Devon. So there's 2 facilities that will be built, each with 10 beds.
Thank you, Nora. So we live in hope that there will be enough places for everyone who needs them, hopefully. I hope this is okay to bring it up here, but information that I've got about the Integrated Care Board is that it's facing a deficit of 31.7 million and plans to make efficiency savings of 96.3 million. So bearing in mind that the health sector is the largest sector in Baines, employing 18,000 people, what impact will these cuts have on our services in Baines?
Yeah, so I think at the moment what we're looking at, across the country, all ICBs are facing significant financial pressures, much like local authorities. So I don't think we're unique in that respect. The numbers that you talk about are challenging numbers in terms of efficiencies that we need to find. There is a requirement on integrated care boards, the same as local authorities, that we have to have a balanced financial position. So we're looking at doing that over the next 3 years and then 5 years. It's a requirement that we have to submit those financial plans. So at this moment in time, I can't say what the exact direct impact will be on specific localities, because clearly we're looking across the 3 localities, but more broadly across the system. So obviously our acutes, primary care and community care. When we know more and when we have more detail of those community plans, clearly I can come back and let you know if there's anything that we need to be thinking about from a locality perspective.
Yes, and I think that's a good action plan to have for the future. But the other thing I want to ask is the fact that our BWS ICB, along with other ICBs, have agreed, I think, a way of saving money by agreeing to a single bank rate, so reducing pay in one way for workers. It's like supply teaching. You get a bit more money, but you don't have any pension rights or anything like that. So this is going to affect a lot of our the workers, our residents in Baines, but also services in Baines as well. So could you comment on when this is actually going to happen and what effect it's going to have, and will it save you the money that you think it will?
I think, if I may, Chair, that might be one that I need to take away just in terms of detail. I think what I will say is that obviously we need to look at all the workforce challenges that we've heard about today and think about how do we appropriately make sure we've got the workforce that's fit for the future that we need. I think it's fair to say that we know that some of the costs, with reliance on agency, etc., it would be appropriate to be looking at those. But I think the specific questions that you raise, if it's okay if I take those away and get a proper answer back, Chair, that's what I would prefer to do.
Thank you. Maybe this is a naive question, but I am slightly surprised that, within not very long of being set up, ICBs are facing such deficits.
Yeah, I think, again, Chair, this is not new. I think it's fair to say that some of the deficits are historic, and that we know that, this has been across health providers as well as CCGs prior to that. So this is a culmination, I guess, of a number of pressures. And at the moment, what we're looking at is what would it take for us to have a balanced financial sustainable plan moving forward. But obviously, our primary concern is making sure that we maintain the quality and the safety of all of our patients and service users. But yeah, I think it's historic, Chair, if I may, and again, not unique to BSW and ICBs.
Again, I'm not sure this has an answer, but it seems perhaps unhelpful that a new entity is set up, such as ICBs, that carries over historic debt. Chris.
Thank you. I was concerned that you were mentioning recruitment, and when you're thinking about salaries and all that, you also need to think about the on-costs. And I was concerned about pension, because people will not go into jobs if they don't think that it is worth it in the long run, and people are looking very much into the future. And having been in an era of luck with teaching and pensions and all that, that is an area that's being eroded at the moment, and I think it's a retrograde step. Thank you.
I don't know if you need to comment on that, but maybe.
Oh, yeah. A comment?
Yes. But I think you're getting our concern, and it would be good, I think, to have more information come. So again, I think another one for our work plan, although I know that the ICB update comes sort of like as a regular item anyway, but thank you. Any more questions on this part, or shall we move on to the pharmacies? And in that case, then, I'm sorry, Eleanor. Would you like to speak? In fact, Eleanor, are you here as a substitute for Leslie?
I didn't know Leslie was here, and she was on this panel, and she hasn't contacted me about substituting. I came because you've got two items on the agenda which are extremely close to my heart, and I wanted to listen to them properly, face to face. Although I have briefed Liz with some questions, but I just had a question that occurred to me. I don't know. You can just jump in and sub. I'm quite happy.
Is that allowable? I'm sure it is.
Could we do a vote?
Are we happy to have Eleanor substituting? I don't think it would normally be a vote.
Okay, all right. So that's good.
Okay, I think in this instance, Eleanor, we'll let you just ask your questions, and that way you may be free to go at a time of your choosing.
Thanks. I mean, I was going to say I'm happy to fill in the form retrospectively, but anyway. It's quite... I didn't expect to hear this part of it, but I'm really interested in what's being said in answer to the questions about discharge and stepping down and care in the community. But my question relates to another area which also has financial implications, to try and stop people being admitted in the first place. I mean, it may have something to do with my age, but I have 3 friends currently and 2 church members who are in hospital as a result of falls with serious fractures. And I'm wondering if there's any way that the work that the Falls Clinic does that can be mediated into the community so that we get less falls in the first place, because there's an element of personal responsibility when somebody has a fall. If we could do you think there's any way we can educate people not to fall? I've been through the falls process in 2018 and I've only had 1 serious fall since then. It's pretty good stuff they communicate. But can you see a way to get it out there so we don't have admissions at this time of year at the rate we are, it seems, at the moment?
If I'd like to come in on that, Chair, I think the answer is yes. And I think we currently have a frailty nurse within the RUH who works very closely with our Community Wellbeing Hub. And we have something called integrated neighbourhoods that we're looking at to see how can we have some more of that provision closer within our communities, because we often talk about the left shift or prevention and avoidance, and the panel may remember that's what the integrated care strategy is based upon, and this is a very live and real example. So yeah, thank you for raising that one today. We are looking at that and doing some work on that with communities, absolutely.
Thank you. Sorry, we were just talking about a potential action, which we haven't fully agreed on yet. Okay, any more questions on this, or shall we move on to the pharmacy?
Just to follow up from Councillor Jackson's question on falling and working in the community. I mean, I know lots of people who have fallen over the years, and I'm just thinking about my own community. How do you reach that community and get that information there? It's not clear. You're sort of like, I can hear you over there in one room with all your money, but I don't see any of that transferred to the local community, and there is a disconnect. I want to know where that connection is.
Yeah, and I agree. And at the moment, what we need to do is work through what that looks like for our integrated community. So we have things, as we've said, like the Community Wellbeing Hub, which again would signpost to these sorts of services. We have these sorts of services, force services, etc., and frailty within the RUH, within community settings. It is about linking all of that together so that we get the prevention and avoidance. So we are doing some work looking at that at the moment, about how we will be looking at that on a multidisciplinary team approach within particular communities, so more targeted.
So again, I'll pick you up. So I mean, my experience is that you get to a certain age where people are older than you and they don't listen to you, and you try and explain to them that they have fallen and they need this support, and they don't want to listen. So some of it actually needs to come with a different age group, like the 40s and 50s who are having to deal with that group of people. How do they know where to go to get that information, to give that information? I think that's the piece of work that seems to be missing.
I think that's very helpful, very insightful, and we can feed that into the work that we're designing. So yeah, thank you for that. And I absolutely take on board that sometimes we need to get to people earlier, but we also need to get to people in different settings, so not making a decision in a crisis or when it's too late. So yeah, let me take that one away and we'll build that in, and we'll come back. I suggest we could probably link that to something around the Community Wellbeing Hub, but let me have a think about that if I may.
Thank you. Yes, that seems quite
My husband might want to come in on that.
Thank you, Laura. I'd also advocate the importance of site tests and regular site tests in this matter, so it may be that I link in with Laura on that piece, especially in the older generation.
And you know, there's other obvious links, such as with Age UK, etc., etc. Yes. So I'm just going to go back to this question about the historic debt, because I think it is a huge worry, and I'm quite surprised, as I said before, that it doesn't look like any moves are being taken by government to write off this debt and to saddle a new enterprise with this. It, just looks like you're creating something that is going to fail. So I wondered if I could ask the cabinet member whether or not you were aware of this debt and whether or not there has been any moves to perhaps to write it off. And is this something you've considered writing to our MPs about?
Yes, I was aware of the debt, and I was aware that the local NHS was taking action to address it. To be honest, I mean, it's happening across the country in the NHS, it's happening across the country in local authorities. I'm aware that our neighbouring local authority, Somerset, it's just gone to One Somerset and is now really, really struggling because it has an awful lot of inherited debt from all the different districts, plus the county council. And, I mean, I fear that any letters to the government will fall on deaf ears. I'm afraid that, that's the situation we're in at the moment, and I think it makes it very challenging for health and care and other aspects of local authority to provide services.
Of course, Liz.
Alison, I'm actually quite shocked that there is this amount of debt, and we weren't really aware of it. I obtained some figures about it when I did a bit of digging around finance, and it is quite shocking that it's this high element of debt with an ICB that's just been set up. I mean, it's a year old, is it? Maybe not even quite a year old. So I just think we've been saddled with a huge amount of money, and we've got all these wonderful plans about, new hospital beds and all sorts of things, mental health schemes in place or are about to be put in place. But we are, we've got our hands tied behind our back because we're struggling to overcome this debt, along with the huge amount of money we have to pay to maintain our services. And of course, and one of the areas will be to cut back on our workforce. And that, we know we've got a real problem, or cut back on the money we pay our workforce. And we've got a real struggle to keep and retain our workforce in the NHS. So, I think we should be doing whatever we can. I'm not going to be political and talk about general elections or anything like that, but maybe we should have something in place for when any new administration comes in, that we look at this.
And also, I think it might be useful to know what perhaps another body like the LGA are doing about this. So perhaps we could have some feedback on this for our next meeting at the latest. Earlier would be better.
Did you want me to go on?
Yeah, I'm sure we can do that. I think, I mean, this has been in the public domain for some time. It's been in the papers of the ICB, and it's something they've been working on for some time. I think, although it does sound like a very large number, it is within the context of a very large budget. And I think if that level of debt were within the local authority, within our context, it would be, unmanageable. I think within the NHS, because the budgets are so much larger, it is not as daunting, but it is nonetheless going to be very challenging, I'm sure.
I think the issue that Liz raises, and I think we'll all be concerned about, is the ability then to develop new plans, when you have this, this debt that ties your hands to deliver.
If I can just come back on that, I mean, in some ways, I think when you have to address something like that, actually it forces you to develop new plans and to think of doing things differently. So I think that will happen. It's just it will be more difficult to maintain the level of service that we want when you've got less money.
Just to say that I think, it's a combination of some deficits that we know about and obviously a changing funding landscape. So some of it is reduced funding in some areas, which again are not new and are known. So I guess similar to what Councillor Bourne is saying, I think it's something that is known and that we need to work through. And as I say, if we have a future action that I'll bring back once we know what those plans might look like, and if there's anything that we need to think about specifically from a Baines locality perspective.
Thank you, Laura. I think we appreciate that. Any more questions on this part? No? Okay. Right, so can we move now to the community pharmacies, and we will ourselves move. Thank you.
Thank you, Chair, and thank you for allowing us the opportunity to update you on community pharmacy. So on the 1st of April this year, the ICB received delegated responsibility for the commissioning and contracting of community pharmacy. There were a number of delegated responsibilities, everything from formal contract management to quality assurance, and the day-to-day running of community pharmacy. That is done along with colleagues working in a Southwest collaborative commissioning hub, previously NHS England colleagues recognising they held the knowledge, the skills there, and were TUPI'd over into a Southwest collaborative commissioning hub, and now work on the ICB's behalf in the day-to-day management of community pharmacy. Oh. No, it stops working. Next slide, please. So a brief overview of community pharmacy across BSW. 145 contractors supported by 2 local pharmaceutical committees. Specifically in Baines, we've got Community Pharmacy Avon. On average across the whole of BSW, as you can see there, a large number of items that are dispensed from our hard-working colleagues in community pharmacy, and also undertake a number of walk-in consultations for those seeking minor illness treatment. The Community Pharmacy Consultation Service has now recently, very, very recently, well, last week actually, been rebranded, but Helen can briefly mention that later on in the presentation, undertake quite a large number of referrals from general practice in delivering that service to patients. And more community pharmacy is being seen as that front door of the NHS, in line working with general practice. So it's a really important part of the community offer, I believe. Next slide, please. So similar to the way general practice works, community pharmacy are independent contractors. They're not directly employed by the NHS. They are seen, like I said previously, as that front door, and often have quite long opening hours, quite often when other parts of the system are unavailable. Traditionally, that role is changing. They are more and more delivering clinical services, such as the minor illness referrals programme, and delivering COVID and flu vaccinations, rather than the traditional role of just dispensing, I say just, but dispensing prescriptions to patients. Next slide, please. So the different types of pharmacy, in the main we've got traditional 40-hour community pharmacy. We have then got another option of the 100-hour pharmacies, who will traditionally be open over a 7-day period, offering long open times. And then we've got distance selling pharmacies, normally online. Those hours, the 40 hours can change their time, but decisions can obviously be appealed. 100-hour pharmacy, that's an interesting one. The regulations recently changed to allow those pharmacy contractors to reduce their number of hours being provided down to 72, as long as they were given 5 weeks' notice. And we have seen a little change in the market since that regulation change, which is obviously having a slight impact. And then additional hours or supplementary hours that community pharmacy provide, again, they can change those by just giving us the 5 weeks' notice. And they're not obviously required to open on bank holidays. That is voluntary. However, we do obviously tend to see some of those community pharmacies coming forward over that time. Next slide, please. Service provision. I'll hand it over to my colleague Helen.
Hi everybody. So I thought it would be helpful just to set out the different types of services within the community pharmacy contract. So that the core that all pharmacies have to provide are the essential services. Those cover dispensing, as you'd expect. Also the discharge medicine service, which is around, with patient consent, their medications on a discharge from hospital being shared with the community pharmacy to try and pick up any, be able to provide support to patients and prevent any errors happening. Bits around disposing unwanted medicines. All pharmacies now have to be healthy living pharmacies, so providing that kind of health behaviour support to patients, so being able to advise on smoking cessation and those sorts of things. And all pharmacies are required to participate in public health campaigns. And next slide, please. The next group of services are what are known as advanced services, and these are optional, so pharmacies choose whether to participate in them or not. And those include the what's been known up till now as the community pharmacy consultation service, supporting around minor illness, taking referrals from GP practices or 111, vaccine services. There's a contraception service, which up until last week was just around being able to do repeat supplies of oral contraception, and that hasn't really got going yet, so I can talk about that a bit more later. There's a hypertension case finding service, so actually that's fantastic for helping pick up people who perhaps have got high blood pressure and don't know, and will really help us tackle health inequalities. And then, as we talked about already, smoking cessation services, COVID vaccines, and what's called the new medicine service, which is supporting people who are started on a medicine, usually for a long-term condition, and providing some additional support as they start their medication. So those are the advanced services. And next slide, please. And then the third group are the local enhanced services. So these are commissioned either by the local authorities or by the ICB. And we have a number around public health, so support with substance misuse, sexual health, emergency contraception, those sorts of services. And then the ICB commissions some pharmacies to hold end-of-life medications. And we have a suite of patient group directions in place, which are a legal mechanism that allows pharmacies to supply a small number of prescription-only medicines to a particular cohorts of people. So, for example, our pharmacies locally can provide antibiotics for urine infections in women. So we've got that local service here. Next slide, please. So I've just said that. We've done really well with this in BSW. We've got most of our pharmacies signed up to provide these PGDs. And actually what's coming now nationally with the Pharmacy First scheme is a national suite of PGDs around minor illness. So we've just started a little bit early. Across BSW, we do around 700 consultations a month across the three counties. So we've kind of demonstrated the value there in improving access for people, that they can get their ailments dealt with in pharmacy, and we can complete that consultation for the patient rather than having to refer them back to a GP or out of hours. We've done a little bit of evaluation work, and I've got more to do, but we can really demonstrate from the data that we have been able to prevent people having to access their GP, so we've been able to care for them in the pharmacy, which is really fantastic. Next slide, please. And the next one. Just to touch on quality, because I know I could talk all day, so I'll keep it short, but just to highlight that pharmacies take part in a quality scheme every year, which is part of their contract, and currently it's got 3 domains within that. So there's a bit around medicine safety, and the pharmacists have all been focused on safe use of anticoagulants, and around holding medicines for palliative and end-of-life care. There's some projects for the pharmacies to do around respiratory care, so helping people use their inhalers properly to get the best from them, making sure people have got asthma plans in place. And then pharmacy has a really important role around antibiotic stewardship and antimicrobial, keeping antibiotics effective, so lots of work around that. Next slide, please. And in terms of assurance, and part of our role now, we've got delegation as we work with the commissioning hub around the community pharmacy assurance framework. All pharmacies participate, they all return a survey, and then there's a more in-depth look at any pharmacies where there might be queries, and a survey of questions covering lots of different areas, including things like have pharmacies got the right standard operating procedures in place, is everybody up to date with their safeguarding training, a huge raft of things that are covered. And then we will do visits to a small number of pharmacies if we picked up any concerns. Next slide, please. This is just touching actually on GP dispensing. So we have a number of dispensing doctors across the patch, and the dispensing services quality scheme is voluntary, but I think all our I'd have to check the numbers, but I think our practices take part. And similarly, a number of indicators that the practices focus on around quality in their dispensing and doing medication reviews, as well as taking part in audit. Next slide, please. I'll hand back to Vicky.
Thank you. So entry into the community pharmacy market is obviously led by yourselves in the local authority through a pharmaceutical needs assessment. We have a committee set up in regulation, the Pharmaceutical Services Regulations Committee, who basically run through any applications for changes or entry and exit from the market, and deal with a wide range of applications, as you can see there. And there is a formal appeals process through NHS resolution. Next slide, please.
Back to me. So I just wanted to touch on what's changing in community pharmacy, because there's a lot happening at the moment, which is really exciting. I'm sure you've all seen the delivery plan for recovering access to primary care, and that plan really sets out an increasing role for community pharmacy in working in a more integrated way to support general practice and help provide more capacity within GP practices. So the plan really highlights how we can expand the range of services in pharmacy and make better use of the clinical skills of the pharmacy teams. Next slide, please. So the things that are coming, I've touched on already. There's the Common Conditions Service, which is being branded as Pharmacy First. That incorporates what's currently the Community Pharmacy Consultation Service. So, as I say, taking referrals from GP practice, 111 and urgent care settings to community pharmacy to help people manage minor illnesses. A proportion of that, a big proportion, will be around self-care and over-the-counter medications. But now we're going to have a national service which has 7 clinical pathways, which you can see listed on the screen there. They're underpinned by patient group directions, as we've had locally previously, so that pharmacies will be able to supply the necessary medicines, even if they're prescription only for these particular conditions. So I think we're in a really great place in BSW to kind of move into the national service. Hypertension case finding, I've already mentioned, that's expanding in that you'll be able to use a wider skill mix of the team within your pharmacy to do those blood pressure checks. And the oral contraception service, which is starting, will allow pharmacies to initiate oral contraception as well as provide ongoing supplies. So again, those services, those last two, are really important with that health inequalities piece. Next slide, please. There's a lot of work happening around digital in community pharmacy, because community pharmacy digitally has not been integrated with anybody else up till now. So there is a lot of work happening with the pharmacy system suppliers so that information will connect back into the GP record. There's work happening to allow pharmacy to have access, with the appropriate permissions, of course, to the bits of the GP record. But obviously, if you're doing a more clinical service, you want to have access to that information. There's work happening around referral mechanisms from GPs out to community pharmacy to make that more slick. So that's all part of a national programme of work, but very much going in the right direction. And then there's some technical changes happening and consultation happening at the moment around skill mix in pharmacy and things around VAT, which I won't linger on. Next slide, please. What we have done locally to try and support our GP practices and our pharmacies work together is we've had some regional funding to ask a community pharmacist to take a lead for each PCN geography, and we've funded them for a day a month to spend time working with the practices, focusing on how we can deliver those new services, build the relationships and improve that sort of communication and collaboration. So that's just up until March, but hopefully will really help us get the new Pharmacy First services embedded. Next slide, please. And then I think that's the last thing I wanted to talk about is the independent prescribing programme. So community pharmacy, or pharmacy workforce as a whole, is changing. And from 2026, all newly qualified pharmacists that go onto the register will be qualified as independent prescribers. So there's a real opportunity to transform how pharmacy and community pharmacy works going forwards. So BSW is part of a national programme of work to test independent prescribing in community pharmacy and look at the governance, the processes, the digital, safety, professional development needs for community pharmacy. So we've got 5 sites that we're going to have across BSW. We're just going through the process of, we've been out for expressions of interest, and we're just going through a selection process at the moment. but we'll be very much part of that work. And our model that we're going to test here is around minor illness, because we felt that really fitted in terms of we've got good participation in the minor illness service at the moment. We've got our local PGDs on top, which have given our clinicians lots of experience, and prescribing really felt like the next step. So really excited to be part of that work and test all of that out. Next slide, please. This is back to Victoria, I think.
So, whilst we have got quite a lot of development and really good work going on within community pharmacy, and that is the right thing, we do need to recognise that it is a changing landscape at the moment. We have seen quite a lot of market exits, both across BSW and we believe nationally. Some of those market exits and along with the changes to the 100-hour contracts, we have seen some quite large providers, national providers, close or consolidate their estates, such as Lloyds and Boots. But working with our colleagues in the commissioning hub, we are obviously ensuring that the correct processes are followed, along with the correct contract management and any sanctions of unplanned closures as a result of that. We are now a part of, like I said, the South West Pharmaceutical Services Regulations Committee, and we are bringing that BSW view into quite sort of specific matters when considering applications. Our colleagues are leading on a rota review at the moment, so looking at the bank holiday provision and opening times of community pharmacy following some of those changes. And the final point, that has now obviously been concluded, as Helen said earlier, on the new scheme and the agreed national funding. Next slide, please. Thank you. So specifically for Baines, and this was current at one point in time, so I will caveat this may have changed recently. So we have got 35 community pharmacies. 34 of those are 40-hour contracts, one previously being the 100-hour, but note that has recently changed to 72-hour provision. Next slide, please. My apologies for the small map there, but I wanted to try and show where those pharmacies are located. Obviously quite a lot around the city, with a small group in Keynsham and around the Midsummer Norton area. Next slide, please. So some of the activity that we've seen across BSW from April, when we received that delegated responsibility, a few number of 40-hour exits, a couple of consolidations and relocations. Specifically for Baines, we have obviously seen the exit out of Sainsbury's, the Lloyds exit out of Sainsbury's, the Midsummer Norton pharmacy reduction in hours from 100 hours, and we have seen the consolidation in Coombe Down, as well as some supplementary hour changes, as you note there. So it is quite challenging. Next slide, please. A brief overview of the support that we provide. I think the main point there really is that we do notify our colleagues at the Health and Wellbeing Board and Health Watch and local GP practices. Our team do provide regular updates, and we actively request patient feedback following those closures. Next slide, please. Workforce update. Do you want to? Yeah.
Yeah, the community pharmacies now, for the first time last year, took place in a workforce survey, and that's just being repeated at the moment. It's going to be ongoing, so that's going to be really helpful. It's important to note we are quite challenged with pharmacy staff in BSW, and actually BSW has the second highest pharmacist vacancy rate in the country, which was surprising to us when we found out. We knew it was difficult, but we didn't realise quite how difficult. So we are working against that backdrop. We've also got similar rates of vacancies around pharmacy technicians, so that is challenging. Next slide, please. I won't go into the detail, but really we've been able to look at the structure of our workforce compared to the rest of the country in terms of what proportion of our pharmacy teams are pharmacists and pharmacy technicians, and then the other support staff. And actually we pretty much mirror the rest of the country in terms of the structure of the workforce. The data just show, like we've just said, that we are slightly shorter of pharmacists, so we are using some of the other members of the team to help with that skill mix. Next slide, please. And when you look at we've taken the data and been able to do some work using our populations, and we can only do this at BSW level. It doesn't break down to the 3 localities. But when you look at the number of this is specifically community pharmacists per 10,000 patients. Actually, we've got the lowest number in the country, and there's a bit of work to understand that a bit further. But I think it's really helpful that people understand that that's the picture of the workforce at the moment. Next slide, please. I just want to say about workforce before we take any questions. We are doing a lot to try and improve that picture. We're working very closely with the university around the undergraduate placements. We are doing a lot to develop partnership working so we can give multi-sector experiences to our trainee pharmacists, and then looking at sort of system roles going forward. So there's a lot of work happening to develop the pipeline. It just takes a little bit of time. Thank you.
Okay, can I start by saying thank you? I mean, there was a phenomenal amount of information there. So I think, I hope I'm not speaking out of turn for the panel, but I would think we might want you to come back when we've had time to digest all of that. I think for future reference, it would be useful, I think, to have such a presentation given to us in advance so that we can then properly look
Chair.
At every single bit of information there.
Sorry, you did already have it circulated prior to the last meeting when it wasn't able to be given.
My apologies. Thank you very much,
okay.
Mark. Okay. But we will still ask you to come back. I think what we'll do is we will perhaps give you some of our immediate questions, but then please expect an invitation to come back. Over to you, Alex.
Well, thank you very much. A lot of information there. The questions I had was, I saw there was one in Keynsham there, and I was wondering which pharmacy in Keynsham that is. And I didn't know that it was there. Is there anything that could be done? Because I know in the community, people haven't heard of this before. Can it be advertised more or anything? Those are my 2 questions.
Yeah, I think as part of the work that Helen's leading on with regards to some of the new clinical service provision, we are also looking at how we advertise community pharmacy. I believe there's work ongoing at the national, and most definitely we are doing that at a local level. Along with patients, and we are working with our Health Watch colleagues. We're about to start working with our Health Watch colleagues as well in the forthcoming year to look at community pharmacy. So yes, most definitely.
So is that...
Possibly, but I wouldn't like to comment. Thank you.
Cool.
Thank you very much. In response to the thing about we got this last time, councillors get a lot of papers and we ditch our papers between... I know some people might save them all, but I don't, so it'd be helpful if it had been resent to us. I've got a couple of questions on the sexual health side. When we've got pharmacists doing this increased workload, and I think it's absolutely the correct way for National Health to go. We need to be doing far more at the pharmaceutical level, but particularly with sexual health, when you get young people come in, particularly young people who haven't reached the age of consent, and it might be a young girl with a young boy, the young boy might be over the age of consent or whatever. What sort of advice are we giving them on sexual health, and is there a process to help them with things like sexually transmitted diseases? How does that work in the sexual health section?
Thank you, Councillor Crosley. I'm happy to chip in on that. Paul Scott from Public Health. So, absolutely, yeah. When giving out emergency hormonal contraception, for example, anyone who either just appears to be vulnerable, could be over 16, for example, but sort of repeat attendance and so on, or who seems to be under any kind of duress, or anyone under 16 is highly likely to be have some kind of confidential safeguarding conversation with the pharmacist, and that's part of the training to be able to give out the emergency hormonal contraception. And we monitor those through the Sexual Health Board and our contract meetings with HCRG, who oversee the community pharmacy contracts, as it were. And so we look at the numbers coming through of people under 16 who are receiving that, and interventions around things like safeguarding. So it's a good question, and it is picked up on.
So what would really concern me is young people who are being manipulated and exploited. Are there mechanisms that we can use that people can recognise when the difference between someone who's coming in because they've just become sexually active at a young age, and someone who's been exploited by elder people for financial gain?
It's a slightly broader question, but there are links, and we have had colleagues from our children's services involved in exploitation work join our Sexual Health Board to look at that. I'm not involved in the sexual health groups. I'm sort of trying to represent as best I can. But to really build those links and understand that, I don't think we have a perception of a significant problem, but there will be instances. Same with our, same with some other kinds of sexual health services as well. But the links are there. I mean, perhaps separately we could get back to you with any more concrete information about that if that's helpful. But certainly be assured those processes are happening to the even local pharmaceutical committee, the Sexual Health Board, and Children's Services sort of exploitation teams. But if you like, we could get back with some more concrete information to questions.
I think we have spoken before about having an item on exploitation and particularly around child sexual exploitation. So maybe we could pick that up within that. We might even want to consider perhaps a piece on modern slavery as well in a future item.
Under any other business, I was going to ask if we could have something on modern slavery, because the figures are quite appalling. There's 50 million slaves worldwide, and the estimate is there's about 125,000 in the UK, which means, statistically speaking, there will be some within BAME. So I was actually going to be asking at the end of the meeting, under any other business, if we could have something on modern slavery, but you can wrap it in with the other bit that you just mentioned. Thank you.
Well, I apologise for slightly preempting you. Joanna.
Just picking up on the point that Councillor Bowman made about where they the pharmacies are in Keynsham. Well, on the East of Bath, you also referenced one. And again, as a ward councillor, I wouldn't know that. So I'm just thinking about the bigger picture, where your dots were on the map. You can basically see there's a geographical region, so the East of Bath, the West of Bath, Midsummer Norton, whatever, you know. Is there a way of actually reaching out to ward councillors in those areas and saying, look, this is where our local pharmacies' work will be growing from, and we want you to be part of that because we're an important way of addressing the community in all kinds of ways. But if we don't even know where that is, and I've come to a scrutiny meeting and I still don't know where that is, we're stuck with getting that out to the community. I certainly know that the local pharmacy where I live in Larkhall is very generous in their time and their knowledge and their support. Again, there are sometimes levels of confidentiality that, not that I think that they've ever compromised them, but you know that you're going in to the pharmacy in your local area and there's often a queue, and somehow it's slightly different to a doctor's surgery. And how do we make sure that people are confident in that confidentiality of whatever their particular concern, issue, need is? And I also raised the point about dentistry. We know that lots of people are suffering from dental health issues, and how a pharmacy is expected to pick that up, again with the pieces of work that are or aren't happening. And again, I hear what Councillor Crosley talked about in terms of contraception and how we take that forward. that does seem to, that's an important piece for women, how women can access that and feel safe in accessing that, and that's ongoing. And then if they move from city to city or region to region, where they know to go to do that with, because that's a real concern for a lot of women.
I'll take some of those and then I'll hand over to Victoria for the dental question. The first part of that around sort of comms and everybody being aware of what services were, I completely agree. There's a big piece of work to do around that. There'll be a bit of digital support with that. Things like the NHS website is being updated at the moment, so if you want to find a pharmacy where you can go for a blood pressure check, you'll be able to put your postcode in and it'll give you the ones within a 20-mile radius. But I completely agree. There's definitely something to do around comms and people understanding what services are available. I think in terms of the confidentiality, every pharmacy now has a private consultation room, and I think we need to just promote that and make sure that people know it's available. The contraception service in particular has to be provided in the consultation room, so that's standard as part of the service. I can only reassure people that we're registered healthcare professionals, and exactly the same rules around confidentiality apply as they do in any other setting. In terms of in terms of all these services, whether it's minor illness or contraception, with the person's consent, the information around the consultation does go back to the GP and into the GP records, because that's where there's the central point where everything is collated. In terms of the contraception service and moving around the country, yes, you could access it anywhere, and the pharmacist, wherever you go, would have to go through the full consultation and make sure that it's still suitable. And I think as the IT and digital integration improves, that would hopefully support that. And dental, I will hand over to Vicky to answer that question.
Yeah, I think looking at, I know that we have got a separate piece on the agenda, I believe, for January. So I'd prefer to pick up dental access in January and give it the merit that it probably deserves, if that's okay.
Yes, that's fine. Thank you. Any more questions before I come to Eleanor? Liz, do you want to ask a question?
Thank you both very much for a very detailed report, and forgive me if I'm going to ask you questions that you've already covered, because it's a little bit hard to read it, and I really would appreciate you coming back, because I don't feel I've done credit to the report that you've given, and I just would like far more information that you have given on it, so it's available to me. But the firstly, I think it's a brilliant idea, and it's good for it to complement what we're getting from our GPs, especially as they are under such pressure. But my first question would be, how are you choosing which pharmacies you use? And I'm very happy to say we've got one in Poulton, and I know it's one because it says NHS on the site, and I think that's the clue to whether they are community pharmacies or not, I believe. You mentioned Lloyd's and Boots, and I'm hoping that you're not just using the chain chain pharmacies, that you're going out to local pharmacies as well. But firstly, I wondered, how are you choosing them, or are they choosing themselves? And secondly, again, I loved math, I'm an ex-geographer, but I wasn't able to see exactly where they were, and I just wondered, will you have one in every settlement over 5,000, for example? Because it looked like there was a big blank in the middle, and again, ex-geography teacher, I can't remember if there aren't very many settlements right in the middle of Baines. But it would be good to know why they're chosen, and have you got a plan to roll this out over a wider area?
Yes.
So, thank you.
I think there's probably two questions within that. The first is around the services provision. Those services, Pharmacy First, are open, all the advanced services, and are open to all pharmacies, so we would hope that they would all take part in that, and that would give us really good coverage. The question about where pharmacies are is slightly different. I'll hand over to Vicky if that's okay for that.
Well, I may refer to my colleague Paul. How we choose community pharmacy, that is a local authority-led process through the Pharmaceutical Needs Committee. Pharmaceutical Needs Assessment. That's led by the Health and Wellbeing Board. And Paul, do you want to go into the process of the Pharmaceutical Needs Assessment?
Yeah, thanks. Happy to do that. So to produce, it's a funny sounding name, the Pharmaceutical Needs Assessment, It is essentially a kind of map of where the pharmacies are in every local authority area and what services are provided over what hours. It's something that has to happen every 3 years. It's published on the Baines website. If you just Google, we can send a link around, but it's just the Pharmaceutical Needs Assessment. It's on the council's website. It includes those maps, so you can look at the maps in more detail if you wish, and it gives the opening hours and it gives the services provided, so it tells you about whether a pharmacy is providing support to stop smoking or flu vaccination, for example, or medicines use reviews and things like that. Obviously, every 3 years, there's quite a lot of change in between. So anytime something happens, for example, a closure of a pharmacy, like Victoria had mentioned, we publish a supplementary statement, and those are also all on the website. And anytime something if it's a slight shift in opening hours, for example, a slight reduction, a supplementary statement will just be published. If it's something more significant, then we have a process whereby we would write to the ward councillors surrounding that pharmacy area, as well as other key kind of partners, perhaps from health organisations like a GP or something, and ask if they have any representations they would like to make that we can then feed back on behalf of the Health and Wellbeing Board to the decision makers, because ultimately it's the ICB and NHS England who will decide on whether any contracts can happen or whether any changes are so significant it needs to be addressed in some way. So the Health and Wellbeing Board has a duty to be assessing the needs, and it's the NHS colleagues who are the decision makers. So if there is a gap in the middle of what appears to be a gap, there's a judgment that has to be made as to whether there's a legitimate difficulty in accessing pharmaceutical services in that area that could realistically be met by suggesting there's a gap and inviting applications for a new pharmacy. It's very difficult at the moment to make ends meet in a community pharmacy, which is why we're seeing all these changes in hours and the closures which colleagues have described. So to just suggest that there's not many pharmacies there means there's a gap is not necessarily a realistic thing. But anyway, it's all on the council's website under Pharmaceutical Needs Assessment.
And I think bringing those applications forward, making community pharmacy more interesting with the development of clinical services, as well as some of the plans, and I would welcome to come back and present to you again, maybe specifically on some of those workforce challenges, as well as the plans that we're developing to address some of those challenges, I think would be fantastic. And I think that's where some of the answer really does lie, because we can have, we can acknowledge gaps all we like, but if we haven't got the workforce to actually open a community pharmacy, then we'd be scuppered.
Okay. I have got you, Eleanor. It's your turn, Eleanor.
Well, I'd like it placed on record that we're very fortunate in Radstock and Westfield in having two excellent pharmacies. I talked to the pharmacists quite a bit, and it seems that the difficulty in staffing both of them, and both have had to reduce hours because they can't get a pharmacist in line with what's been said, is car parking. Now, since the car park in Radstock and the South Road car park in Midsummer Norton, because I suspect there's the same problem in Midsummer Norton, are owned by Baines, and so, well, Elm Tree Avenue is not such a problem. Would it be possible for you or the relevant people to talk to our highways people about giving a parking pass to the staff at pharmacies? If it were just 2 passes in Radstock, it would help enormously. A car parking pass, because at the moment they can only park for 4 hours at a time in a Baines car park, and everything else is taken. I think, they tell me if they could park their cars, they would work more hours. And it's as simple as that. Can we help?
I think that's a factor that probably needs to go to the cabinet to consideration, but perhaps as your ward representative, maybe you could write and ask that question. Ben, but perhaps also we could have that as some of those external factors that affect the likelihood as well as the viability of pharmacies, being spread across, the whole geographical patch. Because, although you said that you had a desire to have pharmacies within a 20-minute walk of everybody, that's going to be another issue, isn't it? And some who need to go to the pharmacy may not be able to walk, and those that are working that pharmacy may live a greater distance away. As we all know, our public transport system is not all it ought to be. Thank you. I had one question actually I just wanted to pick up, and it's about demographics, and it might well have been on one of the many slides, so my apologies if it was. But is there any do you have any evidence around those that are accessing community pharmacies? I'm particularly thinking of students who have to choose whether or not they're registered in one location or another, so may choose to be registered at home as opposed to where they're studying. So it would be useful, if you don't know off the top of your head, maybe to have that at our next session when we have another bite of this.
Yeah, I think we might have to come back to you with that one at the next session. I mean, pharmacy is very different to general practice in that you don't hold a patient list, so you don't necessarily have quite as much information about your patients, but we can certainly look into that and perhaps bring something next time.
Thank you very much. Anybody else want to ask anything else? Otherwise, I think we can safely say we've had a very thorough examination of this, despite, not all of us remembering it or the papers from previous. And in future, will you circulate the slides for us, Mark, so we can look at them again? Thank you. And we'll also need to set up a date for that second bite of the cherry. Right, I apologise, we are running quite late, but we'd like to move on to community resource centres. Because we're running so late, I'm not going to have a break, but if you do need to excuse yourselves for a moment, then feel free to do so. Okay, so community resource centres. Alison.
Okay, thank you. You'll remember at the last meeting that I advised that we were about to start a formal consultation on potential changes to the community resource centres, and that's the 3 care homes, Cleeve Court, Coombe and Charlton House. The decision to consult had previously been published in the local plan, and the consultation started on the 9th of November and runs until December the 18th. A single member decision will be made in January, and we want to hear the views of this panel so that they can be considered with all other feedback received through the consultation process, which has been quite comprehensive. Okay, the background, I'll just give you a bit on that. I'm sure most of you will remember that the CRCs were brought back in-house in October 21, which was in the middle of the pandemic. The services had been underfunded for some years and were struggling. And you're aware of the CQC concerns about Charlton House that were identified a little over a year ago, which were part of that. Since taking the homes back in-house, we've invested in staffing, in training, in equipment, in IT, and in the buildings. And the services are improving, but it's not been easy and it takes time. And we're still within a landscape of staffing problems and staff shortages. But one of the most significant improvements we've made is to reduce reliance on agency staff, which has improved both the quality and cost of the services. However, we're currently in a position where we have a significant number of empty beds across the 3 services, and the current budget for the CRCs is insufficient to run all 105 beds. In addition to that, we're also having to rely on individually commissioned beds for many of our residents who could be cared for in our in-house services, where we make some changes the way that they're provided. And that's why we're consulting. So we're looking at potential changes to the way that we deliver the 3 services, And I'm going to hand over to Anne to talk through the proposals and also to provide information on the consultation process. Thanks.
Thank you. Over to you, Anne.
Thank you, Chair. As you can see in the report and also on the Baines public website, the consultation is live and will be live until the 18th of December. To date, we have had 35 online responses to the consultation, and we have had a drop-in session and individual conversations with the relatives and residents of Charlton House, and we have invited by letter any relative or resident of Cleve Court and Coomley to have a conversation with us. So we have had 7 in-person responses in addition to the online responses, and then 3 further responses via email. 45 responses in total, a mixture of staff, relatives and members of the public have responded. A final report will be produced by the beginning of January once the consultation has closed. As you can see in both the report and, as I say, on the public consultation document, we are asking Scrutiny and also the public and staff and relatives a number of very specific questions about each one of the care homes, and we've set out the rationale around that in terms of the needs of our population, the demands in terms of numbers of people who are placed outside of the Baines area, but also, as Councillor Bourne rightly mentions, the cost of running the CRCs, a cost which was inherited by the council as it came back into council delivery. Okay.
Thank you. So can I just be clear? So it says in the paper that a further report to this panel is to be expected. Can I just check that would be before the decision is taken?
I think the decision will be taken, and we will bring it back to this panel for a further discussion on that. And of course, there will be an opportunity to call a decision in if you don't agree with it or if it's not agreed with. But we hope that through having this discussion, you will understand more fully the reasons why we are making these proposals. And also through the consultation process, we will understand people's reactions to the proposals and their concerns and know whether or not they are mitigated within what we're proposing.
Okay, it does actually say in the papers that recommendations following the consultation, so officers to bring back a further report to the panel prior to the single member decision. So that's what I was just double checking. So what you're saying then is different to what it says in this paper.
Thank you, Chair. One thing I need to pick up on, because Suzanne West, I do believe, joined the 7th of December agenda setting meeting, so I do need an opportunity, Chair, if that's okay for me, to just touch base with Suzanne, and we will give absolute clarity. So yes, we did signify that we wanted, of course, make sure that panel were engaged with the whole process, but if we just given me a few days, because Suzanne is out poorly, for us to come back and confirm the exact dates. Just one thing for consideration, apologies, my laptop's up high, is that, of course, with the closing of the consultation on the 18th of December, it's a very, very quick turnaround for scrutiny papers to be submitted on the 5th. So one thing that was discussed last week is about the sequencing of coming back in and whether we could come to the February panel, but I do believe there's not a February panel sitting. So I think there might be some sort of work that we need to do to make sure we get the sequencing correctly, Chair.
Yeah, there is actually now going to be a February.
Wonderful. Then I'm out the loop, so my apologies.
For this item.
Great.
I think I'd just like to stress from this panel's perspective, and I do hope again I'm not speaking, out of turn. We would prefer and we would, I would stress that our strong preference is that we see this before a decision is taken. And if, actually, I think we'd also like to understand the rationale for a single-member decision as opposed to a more public decision being taken, one that's normally taken at Cabinet. I don't know if you can answer that, or Alison should answer that.
I'm not sure that I can answer it either. I think we took advice on what was appropriate, and that was the advice that we were given.
I think you can sense some pushback on that.
Yeah, I would just conclude with that, Chair. I did take advice from Democratic Services and from the monitoring officer, and was advised that a single-member decision was accurate in terms of the process.
Joanna.
I just follow that up. I mean, the Democratic Services might have a process, but it doesn't mean to say that is the process. And because this issue has caused so much concern amongst many residents, I think, I do think that this should be called to Cabinet as a decision, not as a single member's decision, because there's a lack of transparency. And equally discussing the process. We don't seem to be included in the process. It was clear that previously we asked questions on this. We weren't answered in the correct manner. A letter was meant to be written. That wasn't happened. So the whole process is not fit for purpose. There is no point having a scrutiny panel where we spend hours reading papers, coming to meetings, sitting, giving you our advice, if then you just make decisions around it that don't actually care. It's about transparency and accountability of the council to all residents, and that's our job, and that needs to be taking place. And I think as a scrutiny member, and it's not political, that should be what is happening, and we aren't seeing that.
Alison.
Yes, if I could come back on that. It was advertised that there was going to be a consultation process. It was included in the report that there was going to be a consultation process. I mentioned in my verbal introduction that there was going to be a consultation process. But the consultation wasn't yet in the public domain. And the last thing we wanted was for the residents and the relatives of the residents who were in the homes and the staff who worked in them to hear about something that had been discussed in the public domain in a scrutiny panel before they were fully aware of it. So I think it was appropriate that we actually discuss this now that the consultation has started, and it wouldn't have been appropriate. And we weren't, although it was included in the papers, we weren't asked a question on it. Alex asked me a question on Charlton House, which Anne answered about Charlton House, but she also said we can't really discuss any further because we don't want to preempt the process. So I'm not sure what we should have done differently, really.
I do understand the challenge. I feel that something better could have been done in this instance, but I will move to Joanna and then to Alex.
The scrutiny can be held closed sessions, and we could have been given that information as a closed group of people. We were not included in any of that. There are better ways to work with this scrutiny panel, and they are not being done.
Again, could I come back on that?
In fact, yes, I think it would be really useful to know why we couldn't have heard this in a closed session.
And I think that may have been possible, but I am not invited to the agenda setting meetings. And it was at a time when Suzanne was off sick, and I think maybe had Suzanne been here, it would have possibly come through the agenda setting meetings. Oh, hang on, I think Anne has something to add to that. So yes, I mean, we are where we are, but I didn't have an opportunity to discuss it in the agenda settings. I'm not invited to those meetings.
Anne.
Yes, Chair. I can confirm that prior to the last Cabinet Member update, and prior to the single member decision that we requested, I requested a closed session for scrutiny, and I was advised that closed sessions did not take place.
I think that's a matter that we're going to take up. Thank you for that, Anne. Alex.
Just on the aspect of the single member decision bit, I'm just a bit concerned because, as we spoke before, and I appreciate that we had the phone call. I worry if it's behind closed doors and that is happening in that way. A lot of the residents I've spoken to in there and their families, they've lived there for a long time. A lot of them are Keynsham people, and I'm just concerned about the aspect of them being moved out of the town. I know there's reason that, but I just think it'd be nice if we could re-look at it and see if it can be in a more public way, whether it can go to Cabinet or if there's any other mechanism. That's just my concern on it, really.
Thank you. Yes, I think it would be, and I don't know who takes this up, about our collective desire that this is taken in a, within a Cabinet rather than as a single member decision. So Paul and then Joanna.
This is a very large and important piece of work and decision making. So I would like to move that we as a committee recommend the following. One, that it is referred to this committee before going to Cabinet discussion. And secondly, that it is taken at Cabinet discussion, not at single member decision. So I'd like to move that as a motion from this committee on this paper.
Happy to second.
Thank you. I will just check if that is, we are allowed to do that. Yes, we are. Okay. So do we want any discussion on that, or do you want to vote on that? Vote on that matter straight away? Okay. All those in favour? And just note that we also have non-voting members on this panel too. Okay, so I think that is unanimous. Okay, and we will make that an action point for us to. Okay, so I'm just taking advice that as the Cabinet member is here, then we can ask you directly then to take that forward for us, please.
I will take it forward and take advice. I'm very happy to do that. I'd just like to respond though to Alex's question about the individuals concerned, should Charlton House close, where they will end up and what that process will be. Now, we have discussed this with relatives, but I'm going to hand over to Anne to say a little bit more about that.
Thank you. So we have discussed that we did invite relatives to come to a individual drop-in session, and as I've said, we have spoken and contacted each one of the relatives. Some we've had a number of conversations with. It depends on the level of concern. Of the 10 residents who currently live at Charlton House, 4 individuals are originally from Keynsham, 6 are not. So again, we've been talking to relatives and their loved ones just to get an understanding of their journey to Charlton House. And as I say, this is still, and as it says in the paper, a proposal which we are consulting on. So we have not, and it would be wrong to, look at any alternative options for those individuals at Charlton House. We have made reference to some vacancies that we have at Cleve Court, but we would not preempt the outcome of the consultation.
So I did note your hand was up before, Alex. Did you have another question to ask?
No.
Okay. Paul and then Kevin.
I was just concerned, and I've forgotten what she said, but Anne said that she couldn't contact someone for some reason. We were not allowed. Right, that was it. That is simply not true. Who said we can't have a closed session? We can move a motion to exclude the public at any time, surely. So can we have that corrected? Yeah, well, if it is correct, then I think we need it changed immediately.
If I could just respond to that, I will make sure that I retrieve the emails so I get the wording absolutely correctly in terms of whether it was we don't normally have a closed session, it's not. So I just need to make sure that I've got that. But my understanding, and I apologise, both our Dem Service colleagues and Scrutiny, if I read that as we do not have. But I'll make sure that I get the wording out of that email so that we can look at that.
Because even if it was not usually, on this matter, I think that as chair, I would absolutely allowed for a closed session.
Thank you, Chair. On the funding of the three care resource centres, if you do decide to close the Charlton House Resource Centre, will the occupancy rates for the other two establishments be insufficient to put them into profit, if you like, or to keep them going without deficit? And what is the proportion you mentioned about self-funders and having to have more self-funders? What's the proportion of self-funders that would be needed in order to make that, again, a viable concern rather than profitable, but a viable concern? And is occupancy the only consideration? So if they were full, would you still be a viable concern, or would there be other costs that we don't know about?
If I pick up the self-funder element first, so we cannot, or we do not as a council charge more for self-funders than we would for somebody who was funded through the local authority. And at the moment we have around 15% of our beds occupied across the three care homes by self-funding individuals. And that is additional income that helps us to bring the cost of running the services further into balance. Obviously, if people's assets deplete, then the local authority then becomes responsible for picking up the cost of that self-funder, and we would not be asking a self-funder to move out just because they've stopped being a self-funder. In terms of the viability of the homes, so as we've put in the report, it does depend on what we're comparing ourselves with. So if we compare ourselves, as I say, for a general nursing home, we are more expensive than a general nursing home or a general residential home. If we compare ourselves and if we develop the services, particularly as we talk about Coombe Lee, for example, as we've developed our services to support perhaps younger people in the 40s and 50s with more physical disabilities, we compare favourably to the independent market. The other aspect that impacts on our costs is the size of the homes. So Cleve Court is our largest home at 45 beds. Coombe Lee is our smallest at 30, and Charlton also has 30 beds. The independent sector are now building homes with 70 and 80 beds, and that certainly helps with some of those broader infrastructure costs. So all of those factors come into play when we try and compare ourselves. Hence the looking at the more complex younger individuals where we don't often have those placements homes available in Baines, and the market costs then for that are much higher than what we could deliver that service at.
Can you also explain the fair cost of care having to rise and what implications of that are?
So I may very well defer to my commissioning colleagues. So the fair cost of care is essentially a benchmarking tool around rates that are charged within local authorities. So sometimes we benchmark what is a fair cost to pay for that care against the South West, and sometimes we'll benchmark across England. There is more information we can provide to Scrutiny, but we do, for a lot of the places, do match what we see as a fair cost of care, and for a proportion of placements we actually pay above that, and that is just set by the market rates. Laura, I don't know if you want to.
No, I don't have anything to add. I think it would be sensible if we bring some information back, Anne, if that's helpful.
So do you get funded as an authority to place people at the level of fair care or your fair cost of care? Or do you get any funding for placing it, or do you just have to provide a place? So would you get any central funding for each person you put place in the resource centre?
So regardless of the cost of a placement in a care home, whether that be for an older person or a younger person, those costs have to be met from the settlement grant to local authorities. So we are not funded placement by central government.
And if I can just add, some of the costs of adult social care are met through other sources of income for the council, like the council tax. And other things, but yes, we're not funded to the fair cost of care. We do a piece of work to see what is a fair cost of care for a placement, and we usually fund to that. But that's not reflected in the amount of funding that is allocated to us.
So finally, Chair, if I may, so if I understood it right, if the proposals go ahead, that you currently are looking at stopping provision at Charlton House and increasing or working on the more specialised provision in the other two centres, they will be viable concerns as you see it?
Yes.
Thank you.
And sorry, if I can just add, if we were to close Charlton House, we would close the 10 beds that are currently open, but we would then look at reusing Charlton House within the council for another purpose that meets our priorities. So it would still be used within the council.
Okay. Chris.
You partially just answered my question, in actual fact, because my question was, or rather my comment is that you are losing resources, or could be possibly losing resources that we might need in the future. And that's what worries me. We are an aging population, and more people, I suspect, will need care in the not in the community, although that is the preferred option. There's still going to be there are still going to be people who need 24-hour care within a residential setting, and I just think it's completely short-sighted. That's my reaction to the suggestion.
Okay.
Thank you.
So, Chair, if you'd like me to come back on that, and again, with any further report to Scrutiny, we can provide further information about the number of people who are now going into residential care or nursing care, and the number of people going back to the community. But we continue to see a decline in the numbers of people who are going into sort of general nursing care because of the increase in people's access to community wards and a number of other health initiatives where significant amount of healthcare can now be provided in people's own homes, where we're still seeing demand, and hopefully that is recognised in our proposal, is for dementia care. And again, we're seeing less requests for the older kind of residential care model because people are going home, but we are still seeing demand for, as I say, younger people with a complex physical or needs around learning disability and autism again, and hopefully we've tried to reflect that in our proposals and our thinking.
Did you want to come back? Okay, Alison.
If I can just add, what we're trying to do through this consultation is ensure that we use the local authority resources to target them on the areas of greatest need, and also to ensure that they provide value for money and are affordable. So, we're very lucky, in my view, that we have these resources that we can use to plug gaps in the market, but it's really important that we use them for that purpose and make sure that we are reducing the number of people that we have to send out of area as a consequence of not having services provided locally.
I'd like to look at your proposals in more detail now, and I'd like to just dig a little more deeply into Charlton House. For example, the report states it's going to continue to be used for care, but we really don't have an awful lot of detail. So if this is going out for consultation, I think we need some more detail there. There's a vague alternative care provision and or accommodation. So I think we need to, and the public need to have more information, and when the report comes back to us perhaps in February, that we need to have more information about what this is going to be. You're closing a care home that was purpose-built, has excellent facilities, recently had solar panels put in, which were very expensive, and now it's not going to be used. And we are told that it just isn't viable to keep open because of staffing problems, etc. But I just wonder, what exactly have we got in mind to use this purpose-built, very good facility? So I would be very interested if you can expand on that now, because obviously you're talking about alternative care or accommodation, and I do worry when you say accommodation what that actually means, hopefully not to a developer. Second point I have to make is it looks like an excellent idea to expand Cleeve Court services, because you've said how we need more dementia services, especially looking at complex dementia needs. And savings will be made, which I think we're all, think is a very good idea, from not sending people out of county because it costs a lot of money. And one question I'd like to add, why haven't we done this before? Or is it just that we're looking at the proposals now and seeing what exactly do we need? And would the cost of setting this complex, these dementia wards for complex needs be set against the money saved by reducing what we're doing at Charlton House, or how much funding is going to need for this to happen? And if I can go on, Chair, just a couple more points. The occupancy rates are very low, 67%. Now, I think Chris has mentioned that we're an ageing population. I think the need for care is increasing by 15% per year. So why are our occupancy rates so low? And then we're hoping to raise them to 90%. And how are we going to do this? In how many years? Is this going to happen fairly quickly so that we can generate more money? And I think if you make all the savings that you're hoping to make, I think you've nearly reduced the actual adult social care budget in one go, which is incredible. So these are some of the questions that I'd like you to answer for me. Thanks.
Thank you, Co-Chair. I will try and remember all of those questions. I may need to ask for you to repeat some of them. So if I take the occupancy levels first, so our occupancy levels
have continued to increase across the home, so they are moving from that 67%. Our occupancy levels go back to some of the reasons why we've gone out to consultation is that the things that we are offering now is not what is needed in the future and at this point in time or going forward. So recognising, as I said, there will still be a need for services. It's the type of services. So our basic residential care offer at Coomley is not what is needed. Now, with the staff on board and starting to look at the proposed changes through consultation, we have offered places, as I said, to younger people with more complex needs, which means that Coomley currently has 2 out of its 30 beds now vacant, and we have put forward a proposal to our commissioners about using those beds for respite. We don't currently have respite beds in our services. We would like to make that offer so carers again and their loved ones could have regular respite with us, and if should we need to take somebody in an emergency, the offer would be there from the local authority run homes. Again, in Cleve Court we haven't progressed with a nursing registration for Cleve Court, and again this is still only a proposal for nursing, which we need to consider very carefully, partly due to the difficulties in delivering nursing care at Charlton House. So in having difficulties in delivering nursing care and finding nurses, and a local authority delivering nursing care is very unusual, it wasn't the right time to then think about going into nursing in another one of our homes. And again, that's only a proposal. We are still keen to look at people with complex dementia who need residential. We are starting to make some investment there. Again, the timing was not right because, as Councillor Boyne says, just over a year ago we'd had a flurry of CQC inspections, and our focus needed to be getting the quality right at that point in time as well. So we are continuing again to increase the numbers of people at Cleve Court, but we've made the balance between using permanent staff and bringing agency staff in, and although we've had some good agency staff, the cost of having agency to open those beds doesn't offset itself. I hope I've answered your questions. I'm sorry if I've missed any.
No. There was one more question,
Yes.
which was about alternative use. Yeah, and I mean we haven't gone into detail on that in this paper because this paper is about consulting on the possibility of closure, and we didn't want to preempt that decision, so by saying, and this is what we're going to do instead. But the major gap in provision we have locally is in children's services, where we have very little suitable accommodation for younger people with complex needs who often need residential placements. So that's what it's likely to be, but as I said, no decision has been made. But we are in discussion with children's services, and they're looking into that. So it may well be that that can be discussed in more detail in the next children's session.
What I would say, Alison, is that I think the public do need to know what the future may well hold. The actual proposal is extremely vague. I mean, for an ordinary member of the public, anyone reading it would think, right, you're going to close it and sell it off to some developer for accommodation of some sort or other, possibly within some sort of caring provision. But it doesn't actually go into any kind of information which you've just given to us. It could be said that it's going to be used in some form of provision for people with possibly young people with extreme needs, or older people with extreme needs, or whatever, that it's going to be used as this. In the consultation, it is very vague, and I don't think the public, families, who are responding to the consultation have got any idea. I mean, I had no idea that this is what you might be thinking of, and this is what we as a council might be thinking of, to put a really good use of this building, purpose-built, good facilities, rather than abandoning it with maybe kind of daytime accommodation or daycare offered, to various organisations. This is really the only definite thing that could be happening there. So I do challenge you to think about what exactly you've put there, you are going to put there, and making it clear to the public that this is what is likely to happen. We are not abandoning Charlton House, that we are going to use it and use it for a very good reason, for a very good purpose.
I'm sorry, my laptop's died, so I can't actually refer to the paper. But I think we were, as I said, we weren't wanting to preempt the decision, and we hadn't made a decision either. But yes, when there is a change of use, I'm sure there will be a full, open and transparent process about that change of use. If there's a change of use, there's likely to have to be a planning process. So I think it will be in the public domain. It's just about the timing. I don't know if you want to add anything, Anne.
Okay. Thank you. Is there any more comments on this paper? Okay. In that case then, bearing in mind all of our various recommendations for when we expect to have this paper, or the next part of this decision, I think we will move on. And I am actually going to change the agenda just slightly to bring homeless health in front of food insecurity. I'm sorry, Kathy. Just because it's having a sort of resident expert in the room, I feel it would be important to have this item before Michelle has to go. So, okay. So, Anne, you're going to be called sooner than you expect. Can I ask Alison to introduce?
Okay, thank you, Chair. This is about the health of homeless people in Baines, and it's a very sobering paper because it summarises the health inequalities experienced by homeless people, who are more likely to experience mental and physical health problems. They're more likely to be disabled, and people who remain homeless long term will often die much younger. Homeless people are 6 times more likely to attend A&E, and nationally 66% of homeless people have drug and alcohol problems. That equates to about 160 people if you look at Baines' population. I think it's worth noting in the paper it demonstrates that the annual rough sleep account, which is a national process, underestimates the scale of the problem because it only counts people who are actually sleeping out in the open. It doesn't count people in insecure accommodation who are sleeping in hostels or night shelters. But it does give us a benchmark that we can look at our numbers against every year and see whether they are increasing or decreasing. Nationally and locally, rates of homelessness are increasing, and the cost of living crisis and the shortage of affordable housing are putting many more families at risk of homelessness. These numbers have increased by 40% in Baines in the last year, which is an extremely worrying statistic. Just in relation to the healthcare provision, Baines provides dedicated homelessness healthcare services, which are located in homeless services and help to improve access. They include support for both physical and mental health. And I think Baines has been seen as an area of really good practice in this area. In addition, our severe weather plans provide additional accommodation during cold weather. And at the moment, we have additional OHID funding to increase access to substance misuse services and to make it easier for people to engage with those services. But again, we only have a proportion of the people locally with substance misuse who are engaged in services, so there's more work to be done there. So I'm going to hand over to my colleagues now who have a lot more expertise than I do in this area.
Okay.
Thanks, Councillor Bourne. So I can talk about any of it that's helpful, my colleague Anne from Housing Services likewise can talk, because it's the work is, in a sense, across a number of different departments, really. A lot of the work around supporting people from a housing perspective, but also the broader aspects around that, and colleagues lead. The healthcare provision is led by the Integrated Care Board, and the aspects around drug and alcohol treatment is led by Public Health. And then there's broader bits that are in the report as well, around looking at things like vaccination during the winter for seasonal flu or COVID. And so there's a number of different things happening across different agencies. So I don't know if it's helpful. I can talk through some of the headlines from the report, or conscious of time, you could direct us to aspects of the report that you'd like to pick up, whatever's most helpful.
I think we're, in the interest of time, I think we'll talk about the items that we're particularly interested in, but feel free to add in other information within that. Michelle.
Thank you, and thank you for moving the item, Chair. That's very, very kind of you, and thank you for picking me up as an expert as well. I've got a couple of questions. So first of all is, I noted in the report in the paragraph, I think it's paragraph 3.2, talking about, I just wanted to check that those figures are people who are at risk of homelessness, and obviously homelessness just doesn't mean rough sleeping. Homelessness means homelessness. Are those figures people who are at risk of, in the near term of rough sleeping? And do those figures also include children? Are there any children included in those numbers? That was my first question. My second question is what are the reasons, do you think, for the rising numbers of people in homeless situation? I've got some ideas, I think, but it'd be good to know, from your side, what you think those are. And then the last bit is about statutory duties to rough sleepers and what sort of what happens when they get housed somewhere in temporary accommodation. What levels of support are given? Because in talking to, I help with a soup run, and talking to a lot of people that we help on that service, there's quite a few people who've been housed who really struggle when they're in housing because they feel like the support slowly falls away from them, and I don't know whether that's a perception thing, whether that actually happens. So it'd be good to get some information about that as well. So sorry, I've just bombarded you, but thank you.
Hi, I think the report focuses mainly on rough sleepers, if I'm right. It's Paul's report, really, but there is mention of families in there. The health needs of families, I think, are probably less well understood from our end, from the housing end, than those of rough sleepers and single people. So that's the first question. I can remember your last question. What was the middle question?
The middle question was about what is causing the rise in numbers.
Okay. That can be, as you probably know, it can be quite difficult to nail down exactly why we're seeing such drastic increases in homelessness. We think the cost of living crisis is playing a part now. There are a number of factors around private renting as well, so the no-fault evictions are still up there as one of the main reasons for people becoming homeless, and that includes families with children. I think it's the financial position we're really starting to pinch, and we're seeing the squeeze coming out now that people aren't able to sustain situations that were just about managing in before. It's a huge increase, and the team are under an incredible amount of stress and difficulty with placing people in temporary accommodation. Sorry.
I'm sorry, I was going to come back to that actually. Are we confident that the service can support rising numbers of people? I know that's like asking you to look into a crystal ball, but
just a note of caution that isn't one of my services. That would be Mike Chedzo's service. Yes, they're managing because they're very diligent, they're hardworking, and they're putting in an awful lot of effort and time and care. I think everyone in local government is feeling the stress at the moment, but I think that our housing options team is managing, but does feel the challenge, definitely. In terms of support, once people have had, just to answer your question enough on it, in terms of support, so once people are actually settled somewhere and housed, there are a range of services. We've got, in particular, we've got a DHI service called REACH, which is about going into people's homes. It's about being there for helping with budgeting. It's about keeping things on an even keel, and that is really key when it comes to when things start to wobble. You know, again, cost of living crisis or other factors, your mental health, substance misuse, or any other difficulty that starts to impact on your life. Can affect someone's tenancy, can affect the stability. That's when they would go in and try and steady the ship, if you like. We've got a whole range of other services. We've got a second step floating support service as well, that is a specialist mental health floating support service, as they're called. We've also got the services where people are up to the point they're housed. They will overlap a little bit as well and work together to make sure that person is as well set up as they can be. We've got some really good work going on with Julian House and DHI together as the outreach team, and they will make sure that the person is in the best position possible before handing over. We've also got a Housing First scheme. If you're not familiar with Housing First, that is the principle that avoids any need for other conditions to be met before somebody's housed. So there's no requirement to be abstinent from drink or drugs. There's no requirement in any way other than you sustain your tenancy. And it's used internationally, and we're making a real go of it locally. We've got 24 households at the moment in that kind of accommodation, and that's a step up again in terms of housing support. So that's where several times a week there will be a visit, there'll be a sit down with the person to make sure everything's okay, to make sure that they are all the things that they need are in place. That's a much slower system. It takes a lot of time to get someone from the street, because we're talking about people who have no other option. Housing First is targeted at people who cannot go into supported housing because they usually come with a raft of support issues. So it takes a little bit of time to get them used to the idea of four walls and a roof and responsibility and all that brings with it. A little bit of time then to work with, at the moment, just Curo, but we are looking at other providers now, so we can diversify that a little bit. And then settling in time. It's not a straight line, as you know, people's lives don't go in straight lines, particularly if you have high complex needs like these people do. So it's a lot of intensive support. And there are other specialist support agencies as well that we work really closely with to make sure we've got a whole patchwork of covering that person's needs.
Okay. Kevin.
Thank you. When does the council or yourselves get involved when people are on the at-risk side of going into homelessness? Are there things you can do at that point, or do you sadly have to wait until other things have happened and then put in processes and places to get things back?
I'm going to say 2018, because I think that's when it came in. The Homeless Reduction Act came in, and that gave councils the duty to start working with people 54 days before any legal threat of homelessness. So that means we have to get involved as soon as there is any inkling of a housing difficulty. That said, for years now, pre the Act, we've always worked in a preventative way. We will talk to anybody about a housing problem in order to avert a housing crisis. So anybody coming forward with an issue, if their budgets are starting to become difficult, if they have been verbally told but not received a full legal notice to quit, we'll work with them at that point and develop a personal housing plan, refer on to other agencies that can help, and try and work with them to avert homelessness. So there is no... we don't wait until the last minute. We're given lots of running time to do that preventative work. Our work's very much split into prevention, intervention, and resolving the problem.
So the huge increase then in homelessness, despite your interventions at 54 days or whatever of notice, are there reasons why maybe your interventions are that they're not working, or what's causing the increase despite all your great efforts?
I think volume probably is one of the things that, despite all the best efforts, it's still going up. I think probably a lot of people don't come to us in a timely way, despite best efforts to get messages out there that if you come to us in a timely way, there is going to be more that we can do to work with you. We can't see everybody, but we do try to get the word out to all the agencies that the earlier the better.
Sorry, so is there anything in your view that you're saying about getting the message out there, whether there's either something statute needs to be done or something else needs to be done to get that information out to other people or agencies that may be involved, or landlords or people that have to have an obligation to come to you? Or I'm just trying to think, because obviously I assume that the costs are far greater, not only emotionally and everything else, but everything, if somebody has finally lost their home, as opposed to trying to keep people in a...
Temporary accommodation is incredibly expensive, and I think everybody knows that this is one of the big issues for the council, is reducing that temporary accommodation spend. It's a priority, so yes, definitely to that. I think it's something I need to take up with Mike Chedzoy, who's the team leader for the Housing Options team, and see what he's already doing. We're very active members of the Homelessness Partnership. We're in contact with the landlords, local landlords board as well. I'll take that back. I'll take that back to Mike and see if there's anything we can do to spread the word. We do periodically put out social media posts and messages about coming to see us in a timely way if you're struggling. And as I say, we work closely with Citizens Advice and DHI and Julian House and several other agencies to try to make sure that people do know we're there. And we're very front and centre, as you know, from the one-stop shops. It's now, housing is in the title, so we would hope that the profile's raised somewhat with that as well. But I will take that back.
Thank you. I think that's, it'd be really important to try and get that message spread far wider. Joanna?
Thank you. I mean, I know from residents in my ward who've become homeless, they didn't feel that they got any support, and then there was no way forward. And they were quite cross with me and the system that somehow local authority couldn't support them. So I'm interested in your saying there's 54 days and we can help them as soon as they come to us, because my experience is that isn't always what happens or what they perceive as happening for them. So I get there's different sides to the stories.
I think the ambition is certainly to help every person who comes forward. The intention is to help every person who comes forward. The way the law is set out, the duties on the local authority can be quite limited. It will depend on each circumstance. And again, it does come partly around to perception. So there can have been a lot of work that's gone on in the background, but given the statutory duty not being there, perhaps, the perception could have been that nothing was done. It could be that advice and information is being given. That, I can imagine, in some circumstances, doesn't feel like the most that could be done, but it may all be all that we were legally required to do.
Yeah, and I guess there's a certain amount of people who are moved out of the authority to somewhere else. I know that there was a house, in this particular story, I'm being careful what I'm saying, was in another city, and they had to then live in that city, and it wasn't local, and there was a whole load of problems. So I'm careful what I'm saying, but it does seem more complicated. I guess my question to you as a scrutiny panel is, there clearly is there's politics to this at whatever level you look at this. How could we support helping this role better? Because quite clearly what seems to be the issue is that rents are too high, essentially. So what, as a local authority, do we need to look at to take forward and argue for at a national level, even if it is to ask that local authorities have the right to make decisions on certain things. I certainly know in Bristol they're doing some work, aren't they, on renters' amounts and how they set them. We don't seem to be doing that here.
I don't think, no, you're right, that work to control isn't the right word, but to influence rents isn't being done here. I think we are struggling more and more with the rent levels in Baines. It's becoming less and less of a realistic option, and one of the factors that's leading to the increase in homelessness. And I'll take that back as well. I'll discuss with Mike, see what we can do as a team to take some of that up. There is a chink of light in the increased local housing allowance that came out in the autumn budget, which will help. It will increase the amount of housing benefit. If you're eligible for housing benefit, it will increase the amount that can be paid out and hopefully help people with who are in arrears situations. But yes, rents is one of the factors that living in somewhere like Baines is going to make difficult. We hear stories all the time about the extra challenges being the competition around properties burdens that is quite unheard of before. We're seeing unprecedented activities in the rental section, and it is getting more and more difficult. You're absolutely right. I'm not sure at a national level. I know we're among authorities that represent to central government about these things. I think it's something we need to think about.
I just have to be careful about phrasing that because I think we're in danger of going into another panel's work. So can you just think about how you might wish to, what is it you would like to be brought back around the health of our homeless populations? What I would actually like to just ask about is there's a phrase within the papers, just trying to see exactly where it is. It's 3.5, where you talk about homelessness and ill health being intrinsically linked, and homeless households living in an unsettled accommodation are most likely or more likely to experience mental health, ill health. I felt the way that was phrased was a sort of mental health was the effect of living in unsettled accommodation or indeed being homeless. And I wonder whether or not that was accurate or whether it is more complicated and whether or not it's true that a view that I think is quite widely being circulated is that mental ill health can actually be a cause in itself.
Yes, it absolutely is a cause in itself. It's a cause and a barrier to getting settled again. Somebody's mental health is, it can often be the reason their life declines, and the reason they find it difficult to get out of situations as well. And access to mental health care is not easy. I think most people know that it's not quick or easy. We've got a spot in our outreach team. There's a mental health outreach worker specialist seconded from AWP. It's vacant at the moment, but we're working with them to get it filled, because we know that getting somebody into mental health services can make all the difference.
Thank you, Anne. Michelle, and then.
Well, I was just about to offer a bit of personal experience with that, because having had 2 Section 21 notices in the last 12 months, I can tell you it has a massive impact on your mental health, your sleep, everything, because you're just thinking, I've just moved house again for the second time in 12 months, and it does make you... I'm worried now. I'm thinking, what is my landlord going to turn around and tell me I've got to leave that house as well? Through no fault of my own, I always pay my rent on time, keep the house tidy, everything else. So and I'm quite lucky in that I have quite good mental health generally, so it's not had a huge impact on me, really. But it's like, one more time will be the straw that breaks the camel's back.
And I have to say, trying to find a house, there's nothing that, I mean, I was lucky to find where I did, quite frankly, because there's nothing affordable, there's nothing, and if it is affordable, it goes within hours of being advertised. So it's really, it's such an important thing. And I'm really frustrated as somebody who asked the council to write to the government in 2019 to end Section 21 evictions, that here we are nearly 5 years after that, and it hasn't been done. And it just makes me really angry. So I'm going to finish there before I get upset.
Perhaps that's something the Cabinet member could take away then.
Also, just to say, we have monthly conversations with our government person on the rough sleeping side, and this comes up every time. When is it happening? When is it happening? And I can tell you she's as frustrated as we are and as you are. So it's not gone off the agenda, it just keeps getting kicked along the road a little.
I think we all share your frustration, Michelle. I think we all share your frustration, but thank you for sharing your personal story with us as well. Liz.
Thank you, Michelle, for sharing that with us, and it leads me to a question. Do we and excuse me for leaving the room at a critical time, and I'm sorry if this has been answered, but are we concentrating more with homelessness on people who have drug and alcohol problems rather than people who don't have these problems but are still going to be homeless? And do we give a priority to people who have problems such as alcohol and drug-related?
I don't think necessarily. I think there's a smaller cohort. I think the groups that Anna has been describing would be a broader reflection of the community as a whole. Would that be fair? Yeah. And there's a smaller cohort who do have ongoing, long-standing drug and alcohol issues that is probably more particularly prevalent amongst people sleeping rough over the course of a year. So that amongst that cohort, there's definitely more of a concentration around dependency on alcohol, drugs, and poor mental health. But in that wider group, it's a bigger reflection.
I would say it appears disproportionate because the problems in our sleeping population are acute and chronic, and I think that requires more input. I don't think it's at the expense of any other group.
Thank you. Is there any more questions or points anyone wants to make on this item? Okay. Eleanor.
I would just, I emailed a number of questions in, and I hope you'll have time before Christmas, Merry Christmas, to send a reply rather than take the time of the committee up now.
Thank you, Eleanor. Perhaps those questions and the responses could be circulated, so I'm sure we'd all be interested. Thank you. And now we're moving on to our second to last item, which is food insecurity. I apologise that we are running a little behind, so partly due to the fire alarm, but also I think we focus quite a lot on some other items. Okay. Alison, did you want to add anything to the report?
Okay, the panel asked for an update on the work that's been done to address food insecurity locally. And I mean, this is another sobering paper, really, as it shows that the levels of destitution have increased substantially in recent years. And currently 20% of children and young people in Baines live in relative poverty, and that's 6,500 people aged 0 to 15 in a relatively affluent area. There's been a 10% increase in people receiving universal credit locally in the last year. That's from 22 to 23. But what this really shows, I think, is that the social security safety net is not sufficient, and that's the biggest driver for increasing reliance on food banks. There are 3 Trussell Trust affiliated food banks in Baines, and they have seen significantly increased demand since 2017. The figures are in the report. Also, the Baines Council Welfare Support Services are supporting many more residents than they were before the pandemic. And locally, we have additional support provided through the St John's Foundation Crisis Programme, which we're extremely fortunate to have. This just sets out the three main areas of work of the Baines Fair Food Allowance. And that was set up, it used to be called something else, but it was set up in response to a motion that was passed by the Council in July 2019. And it focuses on three main areas of work, which are increasing food affordability, income maximisation, and also listening to the needs of people in food insecurity. And the report gives a lot of detail on the various areas of work there. So again, I think we'll hand it over to questions and responses from my colleagues.
Thank you, Alison. And I'm conscious, and I said this in our pre-meeting, that this work does overlap with another piece of work that I think the Climate Emergency Scrutiny Panel are also working on. And I'm going to suggest my colleague here, Liz, becomes involved in that panel. So again, we can get some, we won't be duplicating work then as well. Kathy, sorry. For some reason, I thought you were sat somewhere else. Yes, I can see you. And thank you for your patience for sitting through the whole meeting as well. So is there anything in addition you'd like to add to what Alison has said?
Well, I think you've summarised that very well, Alison. Thank you. Just to say that, we previously have had two councillor members on the Fair Food Alliance, so there's an ask particularly about whether or not the panel would like to have another member on the Fair Food Alliance, and we welcome representation from this panel. But also to think about, I suppose what we're talking a lot about, this sort of acute crisis that people are in, either through homelessness or not being able to afford the daily essentials in life, is to think about, I suppose, what the panel and the council can do across its wider strategies in a more preventative way to support this agenda. So the types of things that we as a Fair Food Alliance think about are things that are about lobbying, particularly around, so things like the Household Support Fund. People have had that now for 3 years. 3 years that's been coming in, and it amounts to £2 million worth nearly of government funding over this last year. And so there is lobbying going on at a national level through Feeding Britain, for example, for that to continue into 24-25, because it provides valuable support, particularly to families with children during the school holidays, and it provides an additional crisis fund for people who are really struggling. And this report shows that actually, demand around citizens' advice, welfare support, food banks is still very, very high and is very sensitive to government policy. So it's how we can raise awareness of the impact of that at a local level. So the Household Support Fund is one. The Holiday Activities and Food Programme is another government funded. We've got that until I think March 25, but again, it's not secure funding, so that's also been providing activities as well as food to children who are on free school meals. Predominantly that's the cohort during all the school holidays. And there's a campaign at the moment that the Joseph Rowntree Foundation and Trussell Trust and other big national charities are supporting, which is about an essentials guarantee, which is campaigning essentially for universal credit to be able to cover the basic costs of daily living, because as I've said in the report, citizens' advice are seeing lots of people now, new people who've never come to them before, who are already in a negative budget. They can't meet the costs of daily living just because of the pressures people are under at the moment. So it's about raising that level of basic social security support so that people are not pushed to needing food banks. So that's sort of at a lobbying level that we would ask for. And then I suppose at a more neighbourhood level, and some of the research we've quoted in the report has shown the real importance of social connection and social support in protecting people against the risk of food insecurity. And some people may not have that for a variety of different reasons. And so what can be done, or at a parish or town council level or a community group level to think about how social connections are engendered in the community and how we might pick up risk of food insecurity earlier. Because as we've said, there are a lot of very good charities, social enterprises, third sector organisations working really hard to meet demand, and we are also moving our response to be more preventative through wraparound support. You know, as people are presenting in crisis, what wraparound support can be provided. We're also trying to influence strategy, particularly our economic strategy, in terms of, you know, some of the issues have been discussed today about, you know, a living wage, a good quality job with good terms and conditions, so you have some level of security in your income. Those sorts of things are in the economic strategy, and you know that's the type of preventative policy we need at a local level to sort of mitigate some of these, I suppose, drivers at a more macro level. I'll stop there.
Thank you, Cathy. And I think echoing Alison's words, I mean, this is very, very sobering, as you say, when we live in a theoretically, you know, well-off part of the world, that this is the truth as well. Okay, panel, any questions on or any comments? Joanna, then Kevin.
Going back to the thank you for the paper, it was very sobering. Particularly the 6,500 children living in poverty. And bringing that point up, recruiting, you say you want to recruit more schools into the Affordable Schools programme. I guess what are the barriers to schools taking part, and what are their issues in supporting you? Because they're being asked to do a lot more than just teach these days. So that's my first question, if you want to ask that.
Yeah, I'm just going to hand to Millie because she's working very closely with our schools team on that.
Yeah, thank you for the question. I think when we first started that work, there was some funding that became available through public health to assist schools. In the second round, we still had a small amount of funding that we could offer schools. As we go forward, there probably won't be that level of funding. It wasn't huge, but it was an offer, and I think that helped to engage people. What we are finding, though, is that the schools that have become involved with this, it has enabled them to think very differently, not just about the students that they have who are on free school meals, but about actually largely a big part of the project is around raising awareness of those families that are not reaching those thresholds for benefits like free school meals. And what we know about free school meals is that it opens the door to other things. It is a passport to other support. And those families who are just on the cusp of that are often those families that are really struggling. So although we are probably not going to be able to offer that kind of financial incentive, as small as it might have been, then I think now that we've come almost to sort of a critical mass of schools who are involved in this, and they are genuinely finding it helpful, and they are able to make changes to make school more affordable and accessible for their students without it actually costing them money. In fact, it may be a cost benefit for the school themselves to put some of these things in place. So, yeah, we are confident, actually, that we will continue to roll this out, and that increasingly there will be schools within the multi-academy clusters who then start working together as academy trusts, actually, more than individual schools. So I hope that answers your question. I'm very encouraged by the response that we have from schools who are engaged with this.
Certainly school uniform is a massive issue. And the cost of school uniform, and the particular type of school uniform just for sports facilities that are often asked at a secondary level. Is there any way of going back to the schools and really letting them know that, I mean, this is problematic for lots of parents, not just those who are financially challenged beyond, that those are even on the edge, and not even on the edge, it's a shock.
Yes, so that's the issue around school uniform is a very commonly discussed within the schools that we're working with, and it's something that I think policy in school around uniform can take a while to change. That process can be a little bit slow, but in terms of strategies to help parents better utilise pre-loved uniform, let's say, one of the things that was really helpful was schools doing projects like that and reframing it as something that is ecologically sound. So this is not about sort of reframing it away from it being an issue of cost, because there's shame involved in that. That actually puts people off. But when they've reframed that as, actually, this is something we can do as a whole school community that is more ecologically sound, what they find is there is massively more uptake. And there are some simple things like, do we need to have blazers that are embroidered? No, is probably the answer to that. And yes, it's kind of simplifying school uniform. So school uniform, school food and school trips are often the big key things that we're doing quite a lot of work with schools around.
And rugby socks, just need to put that in there. And then picking up on so 4.15 and 4.19 about financial training awareness. What work that you're doing with the Great Western Credit Union, and just generally when people borrow money, how they can clearly go to loan sharks, and how that does have massive implications for people.
So the piece of work that we are embarking on with the Great Western Credit Union is a model that has been very well thought out in Bradford and Leeds. It's a project called Food Savers. And so what they've done in those areas is the affordable food provision that looks like food clubs and pantries, so not food bank. This is a different model where people are coming often on a weekly basis and they're accessing more. There is an exchange of funds essentially, so people are able to access some of their weekly groceries at a very, very reduced rate. So they're more like social supermarkets, that kind of model. And what they've done with the Food Savers project is to align that then with regular small savings accounts, and the projects, the food pantries and food clubs facilitate that savings plan. So that's basically what we're trying to work with. We are working with Great Western Credit Union to bring that here to Baines. And our hope, because of the experience that we can see from that, having worked successfully in other areas, is it can be a game changer in terms of people's relationship with money. So even small amounts of savings and tiny savings accounts, really, which to many of us might not seem significant, are enough to be a small buffer for unexpected costs and so on, and change people's relationship with money. So this is a slightly slow process to embed this within the credit union because of other priorities that they have around their business plan at the moment, but we are moving forward with that. And so some of the schools we're working with are quite keen to see that model, to see if they could actually pick that model up within schools. And we've also had from the Youth Connect South West team about whether they could also implement that model with their young people. So, yeah, our intention is that will move beyond just the food pantries and food clubs.
So again, picking up what this scrutiny panel can do or not do, is there any way that we can be more supportive in that piece of work? Because it's quite fundamental. I mean, even like, on the money programme on Radio 4, they were discussing how young people at schools are being inundated with social media and telling them, how to borrow money in the wrong ways. I mean, it's quite shocking. And also our nature of money. I mean, we don't deal with notes and coins anymore in quite the same way. So therefore, how you save money is different.
I think there are probably two things there. We've also done some work with the illegal money lending team, the National Illegal Money Lending Team, around loan shark awareness. And they have a partner scheme where organisations like local authorities can become a partner. The money that they accrue from the loan sharks that they arrest, essentially, and then they gather their resources, that becomes a fund that the partners of that programme can access to keep rolling out work around financial well-being. So I think it would be in the interest of the council to be an active partner of the illegal money lending team. And the other piece is that as a employing organisation, the council already has a relationship with Great Western Credit Union for the staff here, and so I think there's a double-edged thing there about raising awareness of that for staff to be looking at savings and affordable loans, and then alongside that promoting this aspect of kind of small savings in various community organisations in Baines.
I'm just trying to work out how we as a panel can take something forward with that. And
do you want to give that some thought? Because we can always add that into the panel. The work plan.
Okay.
Okay. Thank you, Becky.
Thank you. If I can just add a couple of things in addition in relation to what the panel potentially could do. One of them is a comment that Cathy made, and it relates to something I think you talked about. There are two hugely important plans that the council is involved in. One is a strategy, the economic strategy, and the other is the local plan, and they are so hugely important for impacting on health and well-being. So there is something about how does the Scrutiny Committee scrutinise the health aspects. So at an officer level, we've been working very closely with our economic development colleagues who've been working on the local plan and working on the economic strategy to look at ways of embedding health. But I just leave with you, there is something around how is the health aspect of those strategies that don't sit in the scrutiny panel, how are they looked at, because they are really important for health and well-being going forward of our population.
Thank you, Becky. And I think it's something we need to take away and have a think about, because I agree that scrutiny role is really important within that. Yeah. Okay. Other questions on this item? Kevin, and then Liz.
Excuse me. Thank you. First question is around contacting schools. Are you working directly with CEOs?
Sorry. So I'm speaking on behalf of my colleague, Claire Laker, really, who is more directly doing the work around working with schools. She has been, she has been in contact with CEOs of the trusts, I believe.
Because with only 6-7 schools in Baines not under a mat, that's the only way really you're going to get a huge culture buy-in, and if you can get the CEOs to buy in, then you'll be there, I hope.
Yes.
The second question is, you mentioned around the area of those families that are really struggling because they don't fall just into the FSM safety valve, if you like, and get the support that all comes with that. So how are you targeting and supporting those families?
Through the Affordable Schools programme?
No, just generally those families that you feel are really struggling but are not in that FSM bracket.
Yeah, okay. So I suppose we're just highlighting those on free school meals because they get access, as you say, to directly the free school meals, but also the support during the school holidays with the vouchers. But things like the holiday activities and food programme is a percentage of children who are not eligible for free school meals but could benefit from those holiday activities and food programme are given spaces. So if schools identify families who are struggling but don't become eligible, they're given spaces. And in terms of the affordable food network and the food pantries, those are open to anyone with in terms of children and families, adults, older people. So they're not linked to the criteria around free school meals. So we publicise the availability of that food support beyond benefit criteria. And of course the Welfare Support Fund that we have as a council and is topped up by the Household Support Fund is also open to a wider group of people. You don't have to be on free school meals. You just need to be on a low income generally. So certain things are linked to free school meals, but on the whole the support available is broader than that. I don't know if I've answered the question. Is there anything else that we could add to that?
Can I just ask one thing, Chair?
One more thing.
Based on your, when you say getting information out to those families, do they go out through schools as well? So that schools could publicise what you're saying for those families that are really struggling?
I suppose it's through the Affordable Food Network. It is, but also through the school hub pages that are. There's a huge amount of resource that's in those through the council's website. All schools have access to that. We definitely promote that very specifically with the schools we work with on the Affordable Schools programme. That all schools have access to that, and we make sure that that's very up to date with all of the ways that people can access support in Baines. So links to the Live Wellbeing's pages, and there's a huge amount of resource there.
I'm just thinking in terms of when people, particularly families, tend to engage with schools on a regular basis, not necessarily engage with the Baines website, but information, if it's going out through schools in different ways or through things that are advertised, or when health visitors or other agencies of the council, in inverted commas, come into contact, then it's more likely to go as a matter of streaming general information as opposed to trying to get people to find a point of getting that support, because many people might not want to say anything about it either.
For sure. So we do have a schools newsletter that comes out from Public Health that goes directly to schools. There's also a huge amount of information that comes through the Free School Meals team themselves. They're very proactive about making sure that on a regular basis information is sent to all schools on any news around support around financial wellbeing. So there are a number of routes in to all schools, and I think when there's replication in those places, so people are hearing the same news from different sources, that can be really helpful to get that message across.
But it is a bit of an age-old problem, isn't it? How do you get the information to the right people? Yes, Jo.
No, as a parent, you get these newsletters, and now because everything is online, you do reach a point where you're saturated, and it must be the same for all parents. So is there another way of using Instagram or social media, or actually having something printed out that the school have to send out to parents once a year, that you then physically have something as a way of reaching people? Because I can see that message can just disappear into the ether, literally.
I think there is mileage in us looking at all of the communications that go to schools from us and seeing if that can be streamlined. I fully appreciate that it can feel overwhelming, and also if that is through digital access, that for some families that might be difficult. I think there's a balance to be struck between trying to get that information out to people and then doing that in a way that is genuinely accessible. Thank you for the question.
And I would agree with you, Jo, there. Sometimes you just feel a bit overwhelmed with all the emails. Liz.
I'm going to be very brief because it's so late in the day, but what I'd like to say is, and I obviously am biased because I'm on the Fair Food Alliance Committee, but they're doing a fantastic job, and it was set up from us here, from the Scrutiny panel which went to Council, and the Fair Food Alliance came out of that. Indeed. Thank you, Dina. But it's doing fantastic work. But the thing I like most about it is not just about food insecurity rather than food poverty, but it's looking at the wider implications, the fact that people in poverty will have food insecurity, and linking income with the fact that people may not have sufficient food because their income is not quite enough, and it's looking at ways of improving that. And I think Jo asked some very good questions about the Savings Union, Western Savings Union, which is a great way of getting people to save and lifting them out of poverty. But the question that I would like to ask is, hopefully this Fair Food Alliance is going to carry on, and is one of the posts supported by St John's Foundation. So hopefully I know partly it's supported by Baines Council, but also by St John's Foundation. So could you confirm that this is going to happen, so the work of this group, which is really important, will carry on?
Thank you. So yes, St John's Foundation have been funding Millie's Post, which we're very grateful for, and we have that funding confirmed until July 24. So we are in regular contact with St John's Foundation, and we have put a proposal for the continuation of that work, and we will, I think we've got a meeting in January with them, but I can't say for definite it will continue, but I can say that we've made a case for it to continue, and we have a very good relationship with St John's, but nothing's guaranteed.
Thank you. I'm not seeing any more questions at the moment, but thank you very much for your work and for doing this for so many years, Kath, as well. Yes.
Within a very challenging environment, that's the thing.
Okay, so I've recognised that we need to consider nominating an additional councillor, so perhaps I'll circulate that request to the panel and see if we have a nomination. I don't want to nominate someone in their absence. That feels a bit unfair. Okay, so thank you very much, and I'm sure we will have plenty more questions for you in due course. So now we move on to the panel's work plan. We've got a number of items that have come up throughout our session today, which I apologise for letting it overrun, but I will just like to take, we had 15 minutes of doing a fire alarm, so maybe that could be a bit of mitigation there. So in addition to what we've spoken about before, I'll just quickly run through items that we discussed at our agenda setting meeting. So in January, we're expecting the school organisation plan, hoping, I don't know if we've had any confirmation about this yet, the special educational needs homeschool transport as a paper, dental services, and also the budget. I'm aware that I've used the wrong term there in terms of discussing money matters. And then February, CRC consultation, leisure and physical health, and community transferred services. So I think that's where we've got to at the moment. We've also then, I'll just quickly go into March, COVID deaths, EHCP, so that's education and health care plans, the education update and sufficiency. So I'm sure we will have some other items we want to add in as well. So the community wellbeing hub, so we need to find space for that. The ICB, is that a sort of more or less standing item as Laura's walking out the door? Yes, okay, so and you've picked up on the areas of interest there. Community pharmacies, I think we would like another look at that. Perhaps we could coincide officers with the slides preceding the meeting. And what else? Is that everything? Sorry? Exams. That's the education. Yes, that's coming up in March, I think. March, because we won't have the information until then. And it gets later and later, doesn't it? Yes. Joanna, and then
Just
Kevin.
picking
and
up
then
on the
Paul.
meeting, so in Debbie Reynolds, I was getting that wrong way around, what she said about the local plan, because I'm just wondering if that is coming up for, I'm wondering where we are with the local development framework, but should we bring the local plan in terms of public health and follow up what she said in some way?
Yes.
There definitely seems to be a piece there.
I think we should, but we'll just need to think about
the
timeliness of that.
I get
Absolutely.
that. I get that, but I do think that's going back to the finances and how.
Is this about the ICB?
No, the Great Western Credit Union, and how she was talking about that issue, about how there's a public there's a public health link to finances, isn't there, and how we look at that. So I guess there's a paper there of some kind that we want. I don't know how you pull that out a bit more, but people really struggle with money, and then it affects public health on so many levels.
But also will have an impact on mental health as well, won't it? So, as we heard from Michelle earlier on that. Yes.
So those that literally coming out from this meeting. I know before the previous chair, we had raised excess deaths because there's been so many excess deaths in the.
Is that to do with COVID?
That was over the COVID thing.
Yes,
it was to do with COVID. Okay, but we were going to have an excess deaths paper about why they thought there were so many excess deaths.
There was a special report, wasn't there?
Yeah.
That was commissioned that we were going to get the
we haven't had that followed up. So if that could be followed up.
Okay, sorry. Did you just say that was to do with COVID or not to do with COVID?
Yeah, no. There was an investigation, which I'm not sure whether Councillor Bourne, you mentioned it, that there was an investigation to check whether the deaths were unusual, inverted commas.
Yes, and I think the university were involved in this.
Yeah,
yes, and that's what we're expecting in March.
Yes, there was an interim report done, and the final report is due, you said in March, did you? I think it was January.
Well, I think we were expecting a paper.
COVID care home study? Yeah, it's done for...
Yes, that's for long period. Well, that's a different issue, isn't it? Yes. So, is that what we're expecting for within March? Yes.
That's in March.
Yes.
And then just another request, just because of a resident. Sickle cell is a major issue for ethnic minorities, and we don't often pick that up, and how they are treated is often inappropriate because people don't understand the needs of the complexity of sickle cell, and therefore they aren't treated properly in the medical profession. So I guess... I don't know if it's a too detailed report, but I just wonder, in terms of ensuring that all of our population are looked after in terms of public health, whether that's something that we should look into.
I wonder if we could phrase that as a question around health inequality amongst different ethnic groups.
Yeah.
Okay. Because also some groups were more... COVID was more problematic for certain groups, for example, as well. So
but also just recognising what the needs are of.
Yes, of course.
Just, and then also I've got down palliative care. I don't think I've ever heard any of us talk about what the palliative care needs are within our community.
Sort of end of life care.
End of life. We're all going to die. I've had lots of experience of everybody dying, and I just recognise that there's no discussion, there's nothing around it, and you don't even know what the systems in place for it are.
But yet it is part of the health and wellbeing strategy. So you have, all of, life's key milestones, and dying well is one of those. So
yeah, it's a milestone every time.
Possibly the final one.
We usually grant.
Thank you. Okay. Right, any other... I did see a whole flurry of hands, and I entirely forgot who was going to speak. Kevin and then Paul.
There was something asked around admissions and the LA powers on admissions, which might come under the school organisation item. It was mentioned last year about the power of the local authority around admissions, and in fact it was mentioned on the 8th of March 22.
Admissions into schools? So
yes, school admissions, and I wonder whether the school organisational plan, it might come into that.
Yes, we did speak about this. And where... Sorry, I'm saying in our agenda setting, and I just can't think what happened to it, because I didn't make a note of it. Oh, it's in January.
Yeah, but so whether it come under a school organisation plan, is admissions going to be under powers of...
Yes, it will be, yes.
Paul mentioned before he became a lead member of the panel report around a report around children's healthcare services and the new ICB. The School Standards Board and its role, and the LA response to the final report of the Independent Care Review and the reset of children's social care.
You might need to write that down for me.
I will. I can send you the email.
Thank you. Okay. Paul. No, I didn't, and I should have done. So modern day slavery. Luckily, Kerry was paying attention. Okay. Have we covered pretty much everything we would want to see in the future? Alison.
Can I just check, because we have been alternating adults and children's, and we've now got this extra meeting in February, and I just wanted to check the date of that, because it won't be in my diary. Okay, that's helpful, right, I'll make sure that's in my diary. And does that then mean that the March meeting is a children's meeting rather than an adults meeting?
It's broadly a children's meeting, although we have got co-decks scheduled for it, so it's...
Okay, maybe I'll just need to look at what's on the agenda and then decide whether I need to be here or not. Okay. Okay.
Yeah, we are trying to
children and adults, okay, but I think I've got, because they were alternate dates, I wasn't expecting to come in January, but I was expecting to come in March. I'm now not needed in March, possibly, so I'll need to come in April, I assume. So perhaps you can resend me the dates, and I'll just make sure I've got the right ones in my diary.
Let's make sure we've got the right dates, and obviously, I think if you're not able to attend, the expectation would be that another member of Cabinet would be able to attend in your place. But thank you. Okay, is that everything? Have we covered everything? Anybody got anything else they want to add? I apologise again for running 37 minutes over. I'm going to close the meeting then. Thank you everybody for your attendance.